start this our CME on the management of dengue in pediatric age group. You are all aware that during this monsoon season has already started, and we are started getting the patients of the dengue in our day-to-day practice, as well as the fewer patients are being hospitalized, and some of are very serious, requiring ICU admission as well. So, this CME will go through every tidbits of dengue, and we'll try to unfold the enigma related to the dengue in pediatrics, starting from the lab test, when to test, and which patients to be admitted, which patient we can send home, what are the common manifestation and as well as the uncommon, which patients need to go to ICU and which patients needs to go to a severe in other modalities of treatment. So we'll discuss everything on that, and we are very privileged to that for this inauguration we have the galaxy of the guest, our chief guest of the today's CME, as our respected Professor Debashish Bhattacharya sir, our respected Director of Medical Education. I shall request Professor Kalpana Datta Madam, the President of West Bengal Academy of Pediatrics, to welcome sir and all the esteemed faculties and the delegates.
Thank you, Mihir, for your kind words and nice introduction. Very good evening to everyone. And on behalf of West Bengal Academy of Pediatrics, I welcome you all. With us, we really have an honor to have with the Director of Medical Education, Dr. Debashish Bhattacharya, with us. Sir. Welcome, sir. And thank you for coming, and in spite of busy schedule, you have joined today for encouraging us. We did this type of webinar a few months back on 2 months back on adenovirus, and our motto is to notice enrich all the pediatricians throughout the state, because as soon as we get the dengue, the only one person is coming out, platelet is not available, platelet not available, especially this means the hue and cry by the medias and all. So this is the enigma that platelet is not the solution of dengue. There are lots of issues, and the fluid therapy, which is the main therapy of dengue, we'll highlight in these sessions. For that, I welcome all the dignitaries, all the esteemed faculties, and I will request sir, Dr. Debashish sir, to say few encouraging words for this webinar. And I welcome all the delegates too. Thank you, sir. And I request Dr. Debashish sir, please.
Thank you, madam, for your nice words. We really happy that all of us have joined here to combat dengue, particularly for pediatric age group. And in this regard, it's just remembering me regarding the Corona days when all of us were waiting on the Sunday evening for webinars, for get ourselves enriched. And it also remembers me that all people in this fraternity joined hands to fight Corona. So quite naturally, we all should fight together for dengue prevention and also its cure, and not to get panicky, be careful, and always encourage people to work in a proper direction with the awareness of the things. And this platform is really a great work you people are doing, and that will be beneficial for the whole of our healthcare fraternity. I wish and pray to Almighty their endeavor really gives us success, and we definitely pray for the small kids that they should not fall ill, and if at all, they should come up healthy in a very soon and go back to the laps of their mothers. Thank you. I will be in the meeting. I will keep my video off, and I will get myself enriched from all of your things as the time it goes. The whole time I may not be available, but I will try to be there as long as possible. Thank you very much, and wish I pray to Almighty all of you also remain healthy and be with people. Thank you.
Thank you, sir, for your kind words and encouraging words. Now, I'll request Dr. Mihir, please. I think I will state it to go to the first session. If so, I think
we can take some encouraging words from Dr. Shopon Roy is there, the scientific chairperson.
No, Dr. DHS sir has not joined, no?
No, DHS sir has not
Okay,
joined.
whenever if he will join, then we'll take few break and ask him to say few words. Now, Dr. Shapon Roy, the scientific chairperson, will take over the stage. Dr. Shapon, please.
Good evening, everybody. And we are really privileged to have our DHE in our this seminar. And I have got my Professor Ritobroto Kundu, my the President of West Bengal, Dr. Shumita Basu, Dr. Bhashwati Bandyopadhyay, Dr. Ognishekhar Chatterjee, and Shukantoda has also joined, Champok and all. In fact, West Bengal Academy of Pediatrics is trying hard and soul to showcase the talents all over the West Bengal and to the needful for the PGTs also. So this symposium, I think, will be helpful for the PGTs for the day-to-day practice in this particular time of dengue. And with that, I'll tell Mihir to start the symposium. Thank you.
Okay, so I will request Shukanto sir and then Ritobroto sir to say quickly few words to regarding this today's CME and encourage all. Shukanto sir, please. Shukanto sir. Okay, sir. Ritobroto sir, please. Yes, sir.
Thank you again, WBAP, and thank you all the persons present here, my colleagues, my seniors, and my fellows, that it was a great opportunity you have given me to share my knowledge about whatever little knowledge I have about dengue. And it's a great evening. I hope everybody will be enlightened and enriched by this deliberation.
Thank you, sir, for the encouraging words. Shukanto sir, sir, can you hear me? Okay, then without wasting much time, we should now go to the main scientific part. So today's the first session is obviously we have to know the virus and how to go for the lab interpretation. And I will request Professor Shapon Kumar Roy, our scientific chairperson, to moderate this session and introduce our esteemed faculty, Professor Bhashwati Bandyopadhyay.
So the first topic of today's evening is virus and the lab interpretation. It will be delivered by Dr. Bhashwati Bandyopadhyay, who herself is a pediatrician, and she first the DCH, and then he continued her career as in microbiology, and she is the professor of microbiology working as in charge of the virology unit, School of Tropical Medicine. She has got more than 43 national and international publications, apart from the textbook of chapter contribution in virology. She is a member of various expert committee, particularly in the West Bengal. She was expert in the COVID testing expert committee of government of West Bengal. So we are hoping a very good discussion from Dr. Bandyopadhyay. So, Dr. Banerjee, you please share your screen and enrich us. Unmute and please share your screen.
Good evening, sir. Am I audible?
Yeah,
Yes.
Okay. Thank you so much, sir. At the outset, I convey my heartfelt thanks to the organizers for inviting me as a faculty into this esteemed CME. Just a little change. I'm now professor of microbiology in the Department of Microbiology of RTPCR Medical College. So I think, yes, let me share the screen. The screen is visible, right?
Yes.
Yes. Yes.
Make
The
it
slideshow
slideshow.
is there. Yeah.
Yes, it's done.
No,
Yes.
It's done, right?
Yeah.
So today's topic, virology and laboratory diagnosis of dengue. So we all know that dengue is the most prevalent mosquito-borne viral disease in humans. And the spectrum of dengue virus infection spans the range from asymptomatic infection to clinically apparent disease to severe disease resulting in the severe forms of dengue hemorrhagic fever and dengue shock syndrome. And also there may be case fatalities. Then symptomatic infections can present as a mild non-localizing fever syndrome or classic dengue fever characterized by intense headache, severe myalgias, arthralgias, rash, nausea, and vomiting. So again, after the febrile phase, the disease may progress to the more severe but less common forms, which includes dengue hemorrhagic fever, which is characterized by abrupt onset of abnormally low platelet counts, leakage of plasma into the pleural and abdominal cavities, and hemorrhagic symptoms, dengue shock syndrome, and that is DHF with evidence of systemic hypoperfusion. And in a small percentage of cases, there may be it may cause hepatitis, encephalitis, or multi-organ failure, popularly known as the expanded dengue syndrome. Now, out of the 190 countries in the world, more than 100 countries are now at risk of dengue. And out of the 7.5 billion people, the world population, more than half, that is 3.6 billion people, live in areas that are at risk of dengue virus infection. The WHO estimates that 50 to 100 million infection occurs each year, although recent estimates indicate that the total number of infections will likely to reach 390 million per year in the next by 2050. Now coming to the dengue virus. So this is the picture of flavivirus. And as we all know that we are much familiar with the picture of coronavirus, where the picture is like a ball with lot of spikes. But here you can see that it is a more of a smooth appearance. The spikes are not prominent and they lie parallel to the surface of the lipid bilayer on the virus. So this belongs to the genus Flavivirus and family of Flaviviridae, and the virus is spherical and it has a relatively smoother appearance, and because the peplomers, they lie parallel to the surface of the lipid bilayer, and the approximate diameter is 50 nanometer. This is the schematic diagram, and you can see that the innermost component is the viral genome, and it is the nucleocapsid core, and it's composed of viral genome and the capsid protein. It is covered by a viral envelope, which is composed of a lipid bilayer, and it is derived from the host cell membrane. There are envelope proteins and M proteins. So E protein and M proteins that are on the surface of the lipid bilayer, and these are coded by the virus itself, the genome of the virus, and these are responsible for the controlling the entry of the virus into the human cell. So this is basically the structure of the virus. The genome intimately mixed with the capsid called nucleocapsid covered by a lipid bilayer, and the peplomers, E and M proteins, which actually are lie parallel to the surface of the lipid bilayer. So this is the gene of the virus, and it is a positive stranded encapsulated RNA virus that belongs to the Flavivirus genus of the Flaviviridae family. It is approximately 11 kilobytes in length and is composed of 3 structural protein genes that encode the nucleocapsid or core protein. The capsid or the core protein, a membrane-associated M protein and an envelope protein, and 7 non-structural proteins, NS1, 2A, 2B, 3, 4A, 4B, and 5. Now, these non-structural proteins are assumed to be involved in viral replication and viral assembly. And not only that, it also may influence viral virulence as well as immune evasion of the host immune response. This is the viral replication. This picture demonstrates the viral replication. You can see there are a number of receptors by which the virus can take entry into the cell, and also some viruses can be taken up by the Fc receptor bearing cells, that is the dendritic cells, the monocyte and the macrophages. I will talk about that a little bit later. And these viruses are taken inside the cell by endocytosis. And the late endocytic vesicles, there the acidification occurs due to influx of proton ions. And once the environment inside is acidified, the viral envelope fuses with the endosomal membrane and the viral capsid is released. Now, this viral capsid, this viral genome is released, sorry. And this genome, it is a positive stranded, positive sense RNA virus. And so it can be directly translated into proteins by the ribosomes, which are attached to the endoplasmic reticulum. And these proteins and also the other genomes are replicated, and they are replicated inside very closed compartments inside the endoplasmic reticulum, which is actually caused by the virus itself, by the viral proteins, the non-structural proteins, so that the virus can evade the host cell immune responses. So they can hide very well inside invaginations of the of the endoplasmic reticulum, multiply there and manufacture the viruses. And then these viruses are transported outside to the trans-Golgi network. And in this process, they again undergo some maturation process, and then they are released into the extracellular environment. Now, coming to the dengue virus serotypes, we know popularly that there are 4 dengue virus serotypes, 1, 2, 3, and 4, and each serotype is capable of causing the full spectrum of clinical disease. There is a 5th variant, dengue virus, dengue serotype 5, but it is not yet reported in India, and it has been seen to be circulating among non-human primates in the forests of Southeast Asia, with occasional spillover into the humans. These serotypes can coexist in the endemic areas because the immunity to one serotype does not afford protection to an infection caused by a heterotypic serotype. Although all 4 serotypes are antigenically similar, they are different enough to elicit cross-protection only for a few months after infection by any one of them. Now, as we know in COVID that there are many genomic variants, so also there are some genotypes in the dengue viruses among the various serotypes. So 3 subtypes have been identified for dengue serotype, 3 genotypes have been identified for dengue virus 1, 6 genotypes for dengue virus 2, 4 genotypes for dengue virus 3, and 4 genotypes for dengue virus 4. So dengue viruses of all 4 serotypes have been associated with epidemics of dengue fever, with or without DHF, with a varying degree of severity. And as we all know that, and because this forum is of the pediatricians, you all know that this year we had a very bad adenovirus outbreak in the beginning, in the months of December to April. Outbreak now, but that was more than this. There was no conjunctivitis there, and this time we are seeing conjunctivitis. So this is due to the strain differences. And also you must have noticed that in 2021, the RSV outbreak was very severe compared to the 2022 outbreak, and because of the strain difference. There may be quite severe cases, some year maybe not so severe cases. So now I enter into the laboratory diagnosis. Am I audible?
Yes.
Yes,
Okay.
ma'am. Yes. Go ahead.
Okay. So timelines of by biomarkers. So this is of the primary infection. You can see that the virus is there almost 1 or 2 days before the onset of fever. So the viremia is already there in the blood before 1 or 2 days before the onset of fever, and then it reaches a peak within 2 to 3 days of fever, and then again after the development of antibodies, the viral load starts coming down. It may remain there up to 5 to 6 days or even up to 9 days, but the ideal time for picking up the virus from the sample is the 48 to 72 hours, or from 24 to 72 hours. And as soon as the virus is there, in viremia is there, the NS1 antigen also starts increasing in the blood levels, and it becomes to a good detectable level within 4 days or 3 to 4 days. It is there from day 1 onwards, and by 4 days, after 4 days, the titer starts coming down. The IgM antibody may start coming up from around 3 to 4 days, reaches a peak around after 5 days, and then it rises for another 2 weeks or so, and then it starts coming down. The IgG comes after the first week. It also starts increasing, and then it remains there for a longer time, as opposed to the IgM. So this is the primary dengue infection, that is people who are facing the infection for the first time. Now this is the secondary, these are the timeline of markers in case of a secondary infection. And you can see that this is the virus is there simultaneously, NS1 is there, but the NS1 and the viral titer comes down much earlier, and the IgG antibody picks up much earlier, and the titer of the IgG antibody is much greater than the IgM antibody titer. So I'll come to this again later on. So this is the brief background on which I will talk about the laboratory diagnosis. The laboratory tests available to diagnose dengue fever and dengue hemorrhagic fever are virus isolation, serotypic genotypic characterization, viral nucleic acid detection, viral antigen detection, and immunological response based tests, IgM and IgG antibody based assays. Analysis for hematological, and also we can have some hematological parameters. Now I'll come to each of these. So this is a picture where we can see that these are the tests on the left side of the picture, which are very much specific. If you can isolate the virus, if you can detect the genome, or you can detect the antigen, the specificity of your diagnosis is much more increased. Well, on the right side of this diagram, the serology, that is IgM and IgG, these are the indirect methods, and these are not so specific as the ones on the left side. But the opportunity for testing the on the right side, that is the serological test, is much more than the opportunity for doing a virus isolation or a genome detection. So the testing for the serological test is, the opportunity is much more. We can test them even in the PHC level laboratories or district level laboratories, but isolation and genome detection, they have to be done in very sophisticated research laboratories. So currently the most widely applied test is the serological test, and among them NS1 antigen detection and IgM Capture enzyme linked immunosorbent assay, or MAC ELISA. IgG ELISA is also there. Rapid tests are there in the commercially available, but it is not recommended by the National Vector-Borne Disease Control Program. Other serological tests which we used to do previously, when in the early 2000s and late 90s, was hemagglutination inhibition and neutralization. But these tests are very much demanding and we cannot do in large scale, so these are not done nowadays. Now, viral antigen detection, NS1 antigen, it is a gene product. It is a product of the NS1 gene, and it is a glycoprotein produced by all flaviviruses, and it is essential for replication and viability of the virus. It appears as early as day 1 after the onset of fever, and it declines to undetectable levels after 5 or 6 days. It may be there in some cases up to 9 days, but the detection level decreases after 5 or 6 days. Present in high concentrations in the sera of the dengue virus infected patients, and can be detected in both patients with primary and secondary dengue infections up to 6 days. Commercial kits for NH1 antigen detection are now available, but they do not differentiate between the serotypes. It can be used as an early diagnostic marker for clinical management. The next most common test that is done is the IgM Capture enzyme-linked immunosorbent assay. It is popularly known as the MAC ELISA. And M for IgM, A for antibody, and C for capture. So MAC IgM antibody capture stands for the MAC. The anti-dengue IgM antibody is usually detectable by day 5 of the illness. However, the time of appearance of IgM antibody varies considerably among patients. All patients may not develop IgM antibodies by day 5. 80% patients develop by day 7 and more than 90% develop by day 9. So appearance may be variable. IgM antibody titers in primary infections are significantly higher than in secondary infections that I had talked in the previous when I was showing the timeline biomarkers. Advantage of this test has the advantage of requiring only a single properly timed blood sample. In primary infections, detectable IgM may persist for up to 90 days, but in most patients, it wanes to an undetectable level by 60 days. MAC ELISA positive results on single serum samples are only provisional and do not necessarily mean that the dengue infection is current one because of the persistence of the IgM antibody for 90 days. So sometimes it may happen that if a patient has died and has only one test MAC ELISA positive, then it's quite difficult to say whether it is due to the current infection or it was due to infection sometime back. Now, this is a picture of MAC ELISA. I'll skip this slide. Now coming to IgG ELISA, it can be used to differentiate between primary and secondary dengue infections. So this is one test where we can differentiate primary and secondary dengue infections. It is simple and easy to perform, but it is very non-specific and exhibits broad cross reactivity among flaviviruses. It cannot be used to identify the infecting dengue serotype, and these tests can be used independently or in combination depending upon the type of the sample and test available in order to confirm. If you have facilities for multiple tests in combination, we can come to a more specific diagnosis. So interpretation of dengue diagnostic tests, if you have a
No. Nate, Dr. Mihir.
Yes.
You are audible. Vashati is not audible.
Not audible now.
I think ask her to put up the video so that she can have Nate.
Mihir, please call her and say to make the video.
Yes, I'm calling. Now Vashti madam to join the pen.
She should share the screen again.
She is not able to join at present.
Oh.
You want to speak to the DHS since he is here?
Yes.
You inaugurate.
Sir.
Madam, welcome DHS sir. And
so good evening, sir. We have already had initiated the session before your presence. Dr. Professor Siddhartha Niyogi, our Director of Health Service, he has joined with us. We are honored to have you, sir, in this digital platform. in spite of a busy schedule and in a holiday like on Sunday only, if you get to relax, and that time also we requested you to join, and you have joined. So we are really grateful and thankful. Sir, please, I welcome you, sir, and say a few words for this dengue webinar we are having. Last time, 2 months back, we had a similar webinar on adenoviral infection, where we had a very much so-called sort of epidemic. It was not epidemic, but a huge surge of adenoviral infection in our state. And we did the webinar to sensitize all the pediatricians around the state and outside the state. And this time also I saw many doctors outside the state have joined. So DHS sir, please say a few encouraging words for this webinar.
Good evening. I think I'm audible.
Yes, sir.
Yes, sir.
So when rain comes, so this dengue starts. This year also not exception, but this year it has started early. Generally the peak comes in the month of September. Anyhow, the rain is not regular, so we are facing problem. And thing is that infants are also infected. Children are infected. So we have lost one child, I think 10 years, I heard in the paper, but which is not confirmed. Anyhow, so we should be careful so that we should not lose any patient due to dengue. And what I suggest, and in our guidelines also it is written, it is better to do the antigen test after 2 days of fever. That is on the 3rd day. So I think you are sure to get the positive result. So this, if we can diagnose and isolate the patient and keep the patient under the mosquito, so the disease will not spread to other people. The thing is that mosquito we are unable to control due to different issues. But this we can do early diagnosis and starting early treatment. And the most important is the fluid maintenance. That should be done properly. And blood should be done. Test should be done twice a day for PCB and platelets. So we all know now how much, at what time platelets has to be given. Unnecessary use of platelets is not required. And all we know that paracetamol is the only drug and other supportive treatment. So you are better acquainted with it. And the most thing is that vector control. So municipality and corporations are doing it good. But this year what has happened, the number of cases has increased in the rural sector much more than the urban area. So this we have to look for. And those who have joined from the periphery, I would request you to look after it and patient to be diagnosed at the earliest and treatment to be given as per the protocol. The protocol is tested. I think the same protocol with some modification is also circulated this year. So I would request everyone, let us understand what is the problem, and we are happy. What are the problems that we are having some failure? And I thank Mihir for organizing such a conference on Sunday, and I saw that there are many participants. I thank everyone for participating, and as Director of Health Service, I am very happy that you all come forward in fighting the dengue. Thank you.
Thank you.
Thank you so much for your encouraging words, definitely. And thank you for joining on this Sunday in spite of your busy schedule. Thank you, sir.
Even sir, Dr. Professor Devasis Bhattacharya, DME sir, also present here, and he has already given his introductory speech when you have not joined. So this is for your information, sir. And thank you for giving us insight over the dengue. Thank you. Over to me.
Now we can start the
She has joined.
portion of
Yes, yes.
Bhashwati Bandyopadhyay's speech. So, Dr. Banerjee, please start. Unmute yourself and share the screen. And please switch off your
sir.
video. Please switch off your video so that there are no disturbance in the connectivity.
So it's visible, no, sir?
It's visible,
Yes,
but put in the slideshow mode. Please
Okay.
put it in the
Just a-
slideshow.
Just a minute. Yeah. So, should I go back to the last slide, or I should start from this slide?
You can
Start from here,
this slide.
the table one. Yeah.
The table.
Interpretation. Yes, interpretation.
Okay. Interpretation. So, if there is a IgM positive in a single serum or IgG positive in a single serum with HI titer more than 1280, HI means hemagglutination inhibition titer, then it is highly suggestive. It is not confirmed dengue, but it is highly suggestive. But if you have RTPCR positive or virus culture positive or IgM seroconversion in paired sera, or IgG conversion in paired sera, or fourfold rise in IgG titer in paired sera, then it is a confirmed test. Now, some of you have a question, what is IgM-IgG ratio? It has been seen that if the IgM-IgG ratio is IgM by IgG ratio is greater than 1.2, then it is a primary dengue infection. But if it is less than 1.2, it is possibly a secondary dengue infection. But now there is a change in the data, and it has been shown that if it is greater than 2.6, then it is primary dengue infection, and if it is less than 2.6, then it is secondary dengue infection. Now, the National Vector-Borne Disease Control Program recommends ELISA-based NS1 antigen detection tests, and this is since 2010. It also recommends IgM Capture ELISA after 5th day of illness. Now, coming to the sensitivity and specificity of the tests, we should all know that all serological tests, they have propensity for false positive and false negative. And they are strongly influenced by the quality of the antigen used and can vary greatly between commercially available products. So in general, 10% false negative and 1.7% false positive reactions have been observed. Now, RT-PCR for dengue virus detection, it has better specificity and sensitivity compared with virus isolation with a much more rapid turnaround time. Usually the RNA detection levels are reduced after the formation of antibodies. So you have to do the test early within 2 to 4 days of fever. It can detect all the 4 serotypes of dengue virus, and it has more advantages in respect of rapidity, quantitative data or quantitative count, viral count can also be done, lower rate of contamination and high sensitivity and specificity. But the disadvantage is that it requires sophisticated equipment and skilled professionals which are needed to carry out this test. Now, laboratory parameters, hematological parameters, I think my clinical counterparts will deal with this much more in detail. So I will skip this slide. And the sample collection, I'll just talk quite a few seconds, that 3 to 5 ml of venous blood should be collected in screw cap vials with appropriate labeling. And if you are planning to do RNA for serotyping or virus detection or virus isolation, then it has to be sent in cold chain. It should not be frozen. The serum should be separated and should not be frozen. Whole blood if frozen, or even if the clotted blood, if it is frozen before the serum is separated, it will be hemolyzed and it will not be used for, it will not be a sample suitable for testing. And if you are planning to do only serology, then it can be transported in ambient temperature. Now, a few data from STM, we can see that although now we can see dengue, we can find dengue in almost all the year round, but there is definitely a seasonal upsurge in the monsoon season. And the younger age group are much more affected than the elderly, but that doesn't mean that the elderly are not affected. They are also, they can also be affected. And we can see that there is a shift in the dengue serotypes. In the year 2016-17, 74% of the samples were dengue virus 2. But, and here, this is one diagram where we can see mixed infection. This patient has Dengue virus 2 and Dengue virus 3 infection, and same with this patient also. But these are all monotypic infections, the other ones. And in
Sorry,
in
madam,
the year
we are
20,
running a bit late, so can you please?
I'll finish in another 30 seconds.
Okay,
So
okay,
this
madam,
is yeah. So this is 2021 data. Here we can see that the dengue 3 is prominent. So from dengue 2, it has become dengue 3. In 2022, again, there is a almost equal dengue 2 and dengue 3. And in 2023, it is again dengue 3 has come up, but this is not the entire, more data has to come in because the season has just started. And this is one slide which is quite favorite. You can see that these are 3 patients who were strongly suspect of dengue. And these patients had some hemorrhagic manifestations. And you can see that the NS1 was positive and the IgG was positive within 4 days. So this was possibly a secondary dengue infection. The IgM was almost not detectable. And this patient was a strong suspect, and it had all the tests were negative. But when we did the serotype, we could detect one serotype from him. So if you are very much suspecting, if there is a strong clinical suspicion, you can repeat the serological test or you can go for a dengue serotyping. Thank you all for your patient hearing.
Thank you, Bandyopadhyay, for your very informative talk. So now I will request Dr. Mihir to go for the next session.
Dr. Shobhan, I think one question is there that to be answered as asked by Dr. Ognishekar Saha. NS1, about the NS1.
So what is Dr.
That Bhashwati can answer.
So Ogni, can you put the question directly?
If the NS1 protein is produced by all flavivirus, then can it be false positive because of the other flavivirus infection? That is the question.
Okay,
Yes.
that is a very nice question. But the kits are now very specific, and they
You can start your video, Bhashwati, maybe.
Okay.
Yeah.
Yes, sir. Yes.
Sure.
So nice question. Yes, but the kits now that are available for NS1 antigen are quite specific for dengue, and we don't do NS1 antigen for other. We are not doing any other test for NS1 antigen for other flavivirus infection. As of now, only dengue NS1 or NS1 test for dengue is available. So you can, if it is a strong clinical suspect and the tests are quite specific, and you can quite nicely rely on the result of the test.
Thank you. So there are one question in the question answer box. I think, madam, if you can answer that in the question QA box, we'll move to the next session. So after the diagnosis and the lab, knowing about the virus is the clinical manifestations. To moderate this session, I will invite Professor Sukanto Chatterjee sir to moderate this session and introduce our esteemed faculty, Professor Ritobroto Kundu sir.
Well, good evening. Am I audible?
Yes, sir.
Yes, sir.
Okay. So it's a privilege to be here, and thanks the organizer to invite, and in presence of our Director of Medical Education and Director of Health Services. I thank again our President of West Bengal IIP, Professor Kalpana Datta, to organize it, and it's a good audience also. I will introduce Professor Ritobroto Kundu, who is not only a professor of Institute of Child Health, is known as infectious disease specialist. So dengue is definitely one of the very favorite topics for him, and I am eager to listen from him And we all know that every disease is changing its course with time. Therefore, dengue, what we learned maybe 5 years back, is not coming in that particular say symptoms and signs and all that. So we need to update ourselves, and let us have this update from Professor Ridharbrata Kundu so that we do not miss it clinically. And the strong clinical suspicion, what Dr. Bharshati has mentioned, we can really keep that strong clinical suspicion, and if necessary, we can repeat the confirmatory test. Over to Professor Ridharbrata Kundu.
Thank you. Thank you. I'm sharing the screen.
Yes.
New share, shall I do?
Yeah.
Sir, it is visible, sir.
Visible, sir. Visible.
হ্যাঁ এটা তো ইয়ে হচ্ছে না, it is not moving.
Sir, right click করুন একটু, right click.
আগে তাহলে ফার্স্টে এ করি শেয়ার স্ক্রিন,
হ্যাঁ শেয়ার স্ক্রিন, ইয়েস।
তারপরে এটা পাওয়ার পয়েন্ট না হলো না, শেয়ার, এখানে শেয়ার, হ্যাঁ এবার হবে। হ্যাঁ, so thank you.
Full screen mode যাও।
Huh? I'm audible and visible.
Yes, sir. Yes.
So thank you all, the stalwarts of WBAP and the stalwarts of health service, to give me an opportunity to speak on dengue. So first of all, let me come. Dengue is a flavivirus, and flavivirus, as we all know, is the arthropod 1 virus. The two important flavivirus which you encounter in our country is dengue and Japanese encephalitis. Flavivirus share a common mode of presentation. It starts with a systemic febrile illness, to be followed by organ-specific manifestation. Each virus has its own predilection, its own den. During the systemic febrile illness, the features are very non-specific, and it is virtually impossible to distinguish from any other viral infection. But there are certain subtle clues which will point out that it might be dengue. And as I've told you, next, the disease-specific manifestation. Whereas Japanese encephalitis infects the central nervous system, the dengue infects the endothelial cells, particularly the endothelial cells of the respiratory and abdomen. These are the two places where it causes havoc, but it can cause elsewhere also. And one very important thing in this arbovirus disease is that if you have a rash in these fevers, then Japanese encephalitis is excluded. So coming to my first case, a 3 and 11 months old male child presented with sudden onset fever with erythema. You can see a flush over the face, body ache, arthralgia. He has injected pharynx and conjunctiva. He is vomiting and anorexia. If you look very carefully at the face of the child, it is a morbilliform rash. Dengue usually presents, not in every case, but quite a good number of cases, either with a morbilliform rash or with a scarlatiniform rash. How does it differ from measles? Measles also comes with morbilliform rash, whereas measles will have almost invariably watering eyes, running nose, and hacking cough. These things are usually not present in dengue. Number one. Number two, measles will start from the face and the hairline at the back and will gradually descend downwards. The dengue is otherwise around. It usually involves the trunk and then it spreads to the periphery. If it is a case of influenza, where the upper respiratory symptoms predominate in form of rhinitis, cough, though fever, myalgia, headache, and body aches are present both in dengue and influenza. But if it is a co-infection with both dengue and influenza together, then it is very difficult to distinguish. You have to depend on laboratory tests. And during the initial phase of dengue, it is not possible to predict the severity, whether your child will go to severe dengue or not. And that's the reason every suspected case of dengue should be closely followed up. So on the next day, his tests were done. His hemoglobin was 13.2, PCV 42, Total count was low, 38,000 only, with a differential of 4644. Platelet was normal. Dengue NS1 antigen was negative, so also the IgM. And coming to the significance of NS1 antigen is only species specific. It is only in there in dengue virus, not in other flavivirus. So NS1 is very much species specific, though it is not serotype specific. And these antibodies, IgG and IgM, they share among flaviviruses. So if your child has received a Japanese encephalitis vaccine only a few days back, the whole IgM and IgG tests will be influenced. So keep this in mind whenever you go for a dengue test. Perhaps the most important findings in the early stages of laboratory done in the first 2 or 3 days is a low total count. In places where these laboratory tests are not available, there is a unique test which is very much suggestive of dengue. That is a tourniquet test. First, preferably should be done in the peripheries. How do you do a tourniquet test? You tie the blood pressure cuff and raise the pressure between systole and diastole and keep it such for 10 minutes. If more than 10 petechiae are seen per square inch in the forearm, then the test is positive. If it is a dengue hemorrhagic fever, it will be invariably positive with a high count. Whereas in dengue shock syndrome, the test is usually weakly positive, and at times it might be not also positive. So this is the test specially made where laboratory services are poor. So most of the dengues will not produce any problem. This is an undifferentiated viral fever. It's a mild to moderate fever, difficult to distinguish from other viral infections. The virus never goes and causes capillary damage. So rash may be present or may not be present. There wouldn't be any bleeding or plasma leakage, and the thing is going to settle as such. But things are not that easy with every cases of dengue. So let's see what happens. In the recent years, the entire classification of dengue has changed. We have taken away those dengue shock syndrome, dengue hemorrhagic fever, because there are some problems with those things. Because many cases of dengue, which are fairly serious, but either it didn't resemble either dengue shock syndrome or dengue hemorrhagic fever. So now we classify dengue, those dengue without warning signs and those dengue with warning signs. Those dengues with warning signs has a high chance to go to severe dengue. That's the reason why the arrow is thick. And those dengue without warning signs, the chances are slick. So that's the reason every child should be meticulously followed up to see the warning signs. And those dengues without warning signs, they will present with almost everything, starting from fever, rash, nausea, vomiting, aches, pains, just like any other viral fever. Perhaps the only clue which might give is a leukopenia to start, and also if you do a positive tourniquet test. And if you do a NS1 antigen, which I suggest for every clinician to do it, not necessarily you have to wait for 3 days, you can do in the first or second day, it is positive. But there are certain cases of dengue where NS1 might not be possibly positive because the antigenemia might be a little bit low. But during the monsoon seasons, your antenna should be up. And the most important warning signs of dengue is pertaining to the gastrointestinal system. A child who has fever suddenly goes into persistent vomiting or abdominal pain and tenderness. So much so, the tenderness is that often we misdiagnose dengue as a surgical abdomen. And I have seen a case where the abdomen was open, appendix was removed, and only the child died due to severe dengue hemorrhage after a few days. So abdominal symptoms are very common, along with there may be sudden enlargement of the liver. There can be fluid accumulation. As I've told you, the two endothelial damages especially occurs either in the abdomen or in the lungs. So it would be very difficult to pick up early pleural effusion, which usually occurs in the right side of the lung. So better to do an X-ray or an ultrasound. And in the abdomen also very little fluid initially starts, and also you can see the edema around the gallbladder. Besides that, there can be bleeding. Bleeding in the form of, there can be epistaxis, there can be bleeding in the oral cavity, there can be subcutaneous hemorrhage and wet purpurias and ecchymosis in the mucous membrane and the skin. But the problem starts when the warning sign goes to severe dengue. There are three important things which you should consider in severe dengue. One is severe plasma leakage. The child goes into shock. As you all know how to diagnose shock, I don't want to tell you again. So this was a dengue shock syndrome of the yesteryears. And you can have fluid accumulation in the respiratory tract and also in the gastrointestinal tract. And this we called as dengue shock syndrome. Or there could be severe bleeding leading to dengue hemorrhagic fever. The bleeding usually occurs in the oral cavity or epistaxis, petechiae, purpura, ecchymosis, or at times in the gastrointestinal tract, or in case of adolescent girls, they might have severe menorrhagia, and very rarely there can be bleeding in the lungs, pulmonary hemorrhage. But besides that, we had some other very important features of dengue, and that is why World Health Organization round about the year 2010, 2011 coined the term expanded dengue syndrome. So this is a very important thing which you should know. What do you mean by expanded dengue syndrome? It will involve other systems and the presentation might be totally baffling. In the neurological system, the child might come with simple as a case of encephalitis or meningitis. He might come with an attack of cerebrovascular accident, cerebral hemorrhage or ischemia. He might come with Guillain-Barré syndrome. He might come with transverse myelitis. In the hepatic and GI, he might come with acute fulminant hepatic failure with fever. You will be thinking that you are dealing with a fulminant hepatic failure, but actually you're dealing with the dengue if it is the dengue season. He might come with severe hemorrhage. He might come with pancreatitis. Dengue presenting with pancreatitis and dengue presenting with parotitis, which is very common. Very common. You can get it, and at times it is there. In the renal system, we can find a patient coming with acute renal failure or hemolytic uremic syndrome. And in the heart, both bradyarrhythmias and tachyarrhythmias might be the presenting feature. So also myocarditis and pericarditis. Acute respiratory distress syndrome, ARDS, and pulmonary hemorrhage are two common expanded manifestations of dengue in the respiratory system. In the musculoskeletal system, the child comes with severe myalgia. So much so, the CPK level is very high, or there can be frank rhabdomyolysis. In the lymphoreticular system, you have seen many cases of dengue coming with HLH, or they can have idiopathic thrombocytopenic purpura. In case of eye, there can be optic neuritis. They can come with hallucination, psychosis, alopecia. These are miscellaneous manifestations. So diagnosing dengue clinically is not easy. Only one thing you should remember: any child coming with any disease pertaining to any system, you should always keep in mind dengue, because the manifestations is protean. So what are the important risk factors? Extremes of ages, either in infancy and old age. If you have a second attack of dengue, then it is usually severe. I'll come why you have a. And if a child, a newborn or an infant who has received antibodies from the mother had dengue just before his childbirth, then if he has a second infection, the chances it will be very severe. I'll come to type. If the two serotypes have simultaneously infecting a person, then it is usually severe. So are comorbidities in the form of obesity. So always remember, it is the chota dengues and mota dengues which are invariably fatal, keep a special eye on these two categories of patient. So this is in the year 2022, we have reported 2,033,000 people in India suffered from dengue. That too, this figure is very minuscule because many dengues are not reported to the authorities, and we have reported 300 deaths. But I tell you, the deaths are much more, so also the number of infection. As I've told you before, that there are 4 types of dengue. Now, coming to this, the antibodies which we produce against dengue is homotypic, not heterotypic. Supposing in the first season, you are infected with dengue virus 1. So your antibodies will be mainly directed against the dengue virus 1. In the second season, you are infected with dengue virus 3. What will happen? Your body will produce antibodies not against the 3, the newer type, but against the older type, dengue type 1. And this is a misdirected production of antibodies which will give rise to severe infection, as we see in cases of secondary dengue. And as we see in case of newborns, the mother has given her newborn a type-specific antibodies, but the next time the infant or the neonate is infected by another type. So there lies the problem of secondary dengue. I want to tell you 2 important things about the dengue mosquito. As we all know, it is the Aedes mosquito which causes. They are striped. They are also known as tiger mosquito. The 2 important things of this mosquito, they cannot fly much. They have a flight range of not even 100 meters. They fly at the most 80 to 90 meters. Number 1. And number 2, they are highly anthropophilic, not zoophilic. That means they'll bite human beings, not animals, unlike the mosquitoes you have in Japanese encephalitis. So in cases of dengue, what you see, the disease usually not in the entire municipality, but it is located in certain wards. So there lies the importance of dengue, that it can be very easily controlled, because it is not the mosquitoes, they cannot spread beyond 80 to 90 meters. And the success of controlling dengue will be very good if you do the proper things. So this is the importance of dengue mosquitoes. So does one strain give protection to the other? It does not give protection to the other. That's the reason why the secondary things are more, dengues are more severe as compared to the first. Now coming to the most important part, the dengue in infants. The dengue in infants is very, very serious, and it is very difficult to diagnose. The chances of an infant going to dengue shock syndrome or dengue hemorrhagic fever or severe forms of dengue is much, much higher as compared to an older child or adults. The 3 most common manifestations in infants with dengue, heading the list will be febrile seizure. They will come as a simple febrile seizure, baffling you totally. You will think you are dealing with a simple febrile seizure. Next important, they will come with an upper respiratory tract infection, only with cough, coryza. Even the fever might not be that high. And the third, they will come with gastroenteritis. But your antenna should be up to pick those cases that they are dengue, not these. And as their body reserves are poor, the chances of going to severe dengue is very rapid. Number 1. Number 2, the laboratory tests are in cases of infants is a little bit baffling. As I told you before, the earliest clue of dengue is leukopenia. But in infants, you don't get leukopenia. At times, you can give a high leukocyte count. So there, the clue also goes away. And the most important thing, because of this high leukocyte count, they are very difficult to distinguish from bacterial sepsis. And often you think that it is a bacterial infection. And the most severe forms are seen in the age group of 4 to 9. Coming to the neonatal dengue, if a mother suffers from dengue 10 days before and 10 hours after delivery, 10 days before and 10 hours, it's a rule of 10, after delivery, the chances of development of the dengue in the neonate is fairly high. And the neonate usually manifests dengue within 4 hours, but it can continue. The chance of manifestation can continue till 11 days. The manifestation of dengue in infancy is little bit different. It presents with rash and thrombocytopenia, hepatomegaly, and at times pleural effusion, gastric bleeding, circulatory failure, and again it will resemble just like septicemia. And it has been seen the severity of dengue in the mother or the mode of delivery does not influence the severity of dengue in the neonates. But again, the diagnosis depends upon the demonstration of antigen, particularly NS1 antigen. And because the antibodies will cross the placenta, IgG antibodies in high level. So diagnosis, again, dengue doesn't have any specific therapy. So your diagnosis will be to some extent on assumption and do take proper care of the neonates. With this, these are the two cases of severe dengue we have reported from our hospital. With this, I'll come to my last and two more cases, small cases. 2-year, 2-month-old girl had fever for 3 days, not associated with URTI symptoms. He had congested throat with few petechiae for last 2 days. This was the initial presentation. After 2 days, on the third day, he had multiple episodes of non-bilious vomiting along with pain abdomen. So this is the first danger sign we coming across the dengue. The child, as usual, was because it's a drowsy, didn't pass urine for 10 hours with weak pulses. So now he has gone into dengue with warning sign. We did an IV line and NS bolus of 40 ml per kg was given, shifted to PICU. First dose IV antibiotic, intravenous normal saline was started, blood investigation sent, and it shows a total count of 13,400 with PCV 48,000, platelet 25,000, high urea, creatinine 0.7, CRP normal, sodium little bit low, potassium high, NS1 was positive. So here we see little raised PCV with low platelet. So most likely the child has gone into the dengue shock syndrome. This is the X-ray. If you look carefully, you can see the fluid in the pleural space in the right side, and also there's slight whitening of the right side of the lungs, which again points out that the capillary leak has started. And the same day in the evening, after doing all this, giving boluses, there was marginal improvement, better pulse and perfusion. The urine volume increased to 1.3 ml per kg. The BP was such, now the child followed command, drank some water per mouth. And again, the blood was sent in the evening for hemoglobin, PCV and platelet. And it turned out to be the hemoglobin was 14.4. The platelet has risen from 25,000 to 50,000. PCV was 43, it has come down from 48 to 43. But again, round over the midnight, again the child became tachycardic, tachypneic and deteriorated. Another NS bull was given, IVF intravenous fluid with 12 ml per kg was started. And as because so much fluid was required, the child was going to drown in his own secretion. So we started with the Himaxil 20 ml per kg. The house staff thought, the resident thought that status improved. But at 1 a.m., a blood report was sent and it came out to be PCV 31 and platelet 30,000. No, the status didn't improve at all. A falling PCV with falling platelets give rise to there is some concealed hemorrhage somewhere. So this is a very important lesson in dengue. You should think of concealed hemorrhage somewhere. So next, there was deterioration in the early hours of the morning, desaturated tachycardia, tachypnea, bleeding from mouth and nose, oozing from the puncture site, urgently intubated and ventilated. So this was the X-ray. The entire lung has white out of the entire both the sides of the lungs. Difficult peripheral cannulization, 4 units of rapid donor platelet was given. Fresh frozen plasma was given, bleeding continued, subnormal BP, dopamine started. But somehow, so to recognize this very important concealed hemorrhage in dengue, you should look at rapid fall in hemoglobin with hematocrit without overall improvement, refractory shock with falling hemoglobin, hypotensive shock at presentation associated with low or normal hematocrit prior to food resuscitation, or if the child has abdominal distension, tenderness associated with or without metabolic acidosis in a child with shock. So this is a very important lesson of concealed hemorrhage, which you cannot afford to miss. I have some little time left. Do I have some little time left?
So it is just you have
So,
exceeded 2
a
minutes.
small case I'll have. So this was the child. Ultimately, by fighting very hard, we could save the child. Now I come to my last and only 2 slides I have. A 10-month-old child has come with fever for 4 days, poor intake. Next day, generalized rash which subsided within 24 hours. Fever continuing with vomiting, 2 loose stools, fluid intake was poor with scanty urine, dry coated tongue. Next day, the child was lethargic, had a general tonic-clonic convulsion. In the emergency department, came in an unresponsive with jerking limbs. His temperature was subnormal, 35.5 degrees centigrade. Pulse rate was 160, BP was there, SpO2 in room air was 94. He had neck stiffness, depressed spontaneously, labored bilateral respiratory bilateral air entry was there, feeble pulse, cold extremities, and raised CRT. So apparently, looking at this history, we would rather think that this is a case of meningitis. But if the history is that of an acute febrile illness with less fluid intake and fluid loss resulting in dehydration. The child was in shock as manifested by rapid pulse rate and feeble pulse, cold extremities, and prolonged CRT. The reason of seizure in this case might be 3. Number 1, it might be ischemia of the brain. Number 2, it might be meningitis or encephalitis. And number 3, electrolyte imbalance. Seeing a child with seizure and neck stiffness, the first obvious diagnosis will be meningitis. But chances of meningitis with a subnormal temperature is very low. So what we have here is a child in dengue shock syndrome with features of central nervous system involvement. So this is a classic case of expanded dengue syndrome. So before we got hold of a report which was done 2 days before coming to the emergency department, his hemoglobin was normal, 11.3, PCB was normal. Look at it, the total count you expect in dengue to be low, but as it is an infant, his total count was not low, it was normal, 9,000. And his differential was high lymphocyte that goes against bacterial infection, and the platelets were normal. In the ED, blood samples was collected, high flow oxygen was given, ceftriaxone started, midas given, and a bolus of 100 ml of NS referred to PICU. In the PICU, the child was in very bad shape, only pain response, occasional decelerate posturing, heart rate 130, normal respiratory effort, subnormal temperature. This was the BP, cold extremities, feeble pulse, high CRT, pupil equal in size, anterior fontanelle circle, petechial hemorrhage and bleeding from the IV site, nasogastric tube. Again, showed 70 ml of coffee ground aspirate. And if you see the reports of the sample in ED, his hemoglobin was 10, PCV 33, total count 15,200 with 63% lymphocyte, platelet very low. Albumin was low, SGPT, SGOT was high, urea and creatine was high, sodium was low. Random blood glucose 260, INR high 1.7. So also the PTT 200 seconds, pH 7.9, PCO2 8.4. So the venous blood gas showed severe metabolic acidosis consistent with shock. But the fall of hematocrit from 33 from the previous baseline of 36 at the time of shock again suggested a significant bleeding. The low platelet count indicates the critical phase of dengue. Though the WBC count is high, but it is predominantly lymphocytic, hence less likely this is due to infection. The coagulation disorder, high INR, PTT, together with raised hepatic enzyme, is consistent with severe dengue with shock and bleeding. So again, I re-emphasize, you should always take a good vigil at this, interpreting the reports. And with this, I thank you for your patient hearing.
Thank you, Rita Bruto, for the nice presentation. And I think Dr. Mihir has many other sessions to continue. I hand over the session to Mihir Sarkar.
Yes,
May,
thank you.
if you allow, may I ask a single question to Professor?
There are
Yes,
three
yes.
questions, sir.
Yes.
There are
Yeah, we
two
can take 2-3
questions.
questions. Yeah.
Yes,
So
yes.
my first question to Professor Ditobroto Kundu, sir.
Ah,
Sir, as you have told, particularly the infants, if they are sensitized by the prior infection or by the transplacental transfer,
transfer antibodies.
antibody. So if the further infection occurs, it may be detrimental. But if we give the vaccine
Vaccine.
to the priorly vaccine, dengue vaccine, in the
Dengue vaccine
previously
is-
infected children, in the
Dengue
previous
vaccine-
dengue vaccine, because Dr. Bhashwati has already written in the chat box. You are then giving the
Dengue
No.
vaccine is not licensed in India. You cannot give.
It is
And
in the
the-
phase 3 trial, is not.
Yes,
No, no.
you know what happened in Philippines, who has a situation like just like of India, because we have already circulating antibodies against dengue. And if you give a vaccine and if the child develops a dengue, it will be a very serious dengue. And in Philippines, the person who has done the trial, he's behind the bar. So dengue vaccine coming to India is little bit,
no.
it will
My
take some
question
time.
is, my question is to whom we can give the dengue vaccine, previously infected or previously non-infected?
So there lies the reason. If the child is previously infected, then the child does not require a dengue vaccine. But making sure whether the child is previously infected. So in case of vaccine is, you have to do a blood test. And these blood tests, what we do, we see the IgG and IgM antibodies. But these antibodies are cross-reacting antibodies. They are present in other flaviviruses. So interpretation of the antibodies will be very, very difficult. So there lies the problem of giving dengue vaccine in a country like us.
Okay, thank you.
Okay, so thank you, sir. Another important question is that what should be the NS1 antigen test in case of neonatal dengue? It will be positive, or what should we do it? That is the question.
Yes, if it is NS1, if it is a positive, antibodies the mother share, antigen also the mother might share. But if it is positive and if it is consistent with the findings in the child with that of dengue, then you can take it as dengue, because dengue does not have any specific medicine. All dengue needs is a supportive therapy. And there are quite a good number of infants who might not develop the disease in spite of getting the virus. So every case where the mother has a dengue 10 days before, 10 hours after delivery, you take the child is a high possibility of suffering from dengue. So that child should be kept under strict vigil, so that the child should not go into shock. His fluid balance should be meticulously taken care of. His platelets, his hematocrit should be regularly done, and he should be in a closed vigil for next 4 days, because the chances of developing clinical dengue is maximum on the 4th day after delivery. But the chances of developing clinical dengue can continue till 11 days after delivery. So that is the period you should keep the child under strict observation.
Yes, thank you, sir. There are a few questions in the chat box. If you get time, you can answer, or we can later on answer it we move forward to the next session. Sir, can you please stop your sharing your screen? Yes.
Yes.
And there are a few questions in the chat box, sir. Please answer.
Steroids are not helpful in dengue at all. Don't give steroids. They are not helpful, and the steroids are only for people who are working in the critical care, just like Mihir and other Agnishekar. But we as a pediatrician, general pediatrician, we will never recommend steroid to be given in dengue.
Sir,
Okay.
sir, please answer some questions in the chat box. Just
Chat
post
box
it in the,
are
write
the
it in the
question.
chat
No,
box.
sir,
Question
if you
nahi
can write it in the chat box, or I will send it to you. Now we move forward to the next session. There is we're already 15 minutes late. So next session is very important to how we manage the dengue in day-to-day practice in our OPD, and also the patient who are getting admitted in the inpatient department. So there will be a more panel discussion. In panel discussion, today's moderator is Professor Sumita Basu, madam. Professor Sumita Basu is the professor of Pediatrics at RK Hospital and Vivekananda Institute of Medical Sciences, Kolkata. And Madam has a great work on the child neglect, child abuse, and the child labor, and working on this field for a long time. And we have an esteemed panelist, Professor Dr. Amita Sinha from Divine Hospital, Dr. Sharbani Mishra, Madam from Malda Medical College, the Assistant Professor, Associate Professor of Pediatrics, Dr. Volanath Aich, who is also the Associate Professor of Pediatrics from Murshidabad Medical College, and young and dynamic Dr. Nilanjan Ghosh from Assistant Professor from RGCOR Medical College. Over to you, Madam, for starting the panel discussion.
Thank you, and good evening, everybody. I hope I'm audible and my slides are visible.
Yes, ma'am.
Okay, so welcome to my panelists. I'll straight away today, my job is to talk about management of dengue in outpatient department as well as in the ward. So straight away, starting off with a case, 5-year-old boy came to the OPD with a history of fever for 4 days along with headache. He vomited several times and his intake was poor, but there was no other complaint. On examination, his weight is 30 kg with a BMI shows obese percentile. He's febrile with a temperature of 100. His peripheries are warm, face is flushed, and his pulse is 100 per minute. But there was no dehydration. His blood pressure was 90/60, throat was normal, and his systems was all normal, and there were no meningeal signs. So my question to Dr. Sinha, what is your provisional diagnosis and what will you do for this child? Dr. Sinha, please.
Yes, thank you, ma'am. Good evening, everybody. So this is a case of a 5-year-old boy who has come to the OPD with a history of 4 days of fever and vomiting. So the possibilities in this case, we would keep of a viral fever and the second possibility of dengue because of the epidemiological preponderance in this season. And then we would also think of malaria, typhoid, viral hepatitis, etc. So what we would order is already 4 days of fever, no viral symptoms as such, cough, coryza. So the case we should have a more inclination towards thinking of dengue. So we have to order tests like the complete blood count, NS1 antigen, and also since it is 4 to 5 days of fever, we will also go for dengue IgG and IgM. And malaria antigen, and if possible a blood culture to rule out enteric. And in the management, because he is a obese child, so we will of course ask the patient to be managed on an OPD basis, but keep warn the parents about the possible like even if the child becomes afebrile in the next 1 or 2 days, in case the child comes out to be dengue, the critical phase would be the next 1 or 2 days, and we have to enumerate on the signs of repeated vomitings, pain, abdominal tenderness, and restlessness, etc. We have to emphasize that even though the child becomes afebrile, they have to report in case of these symptoms. And for the management in an OPD basis, we have to give the child lots of fluids, oral fluids.
Okay,
and
thank you, Dr. Sinha. I'll come to that question a little later. Now, this child has a comorbid condition, like you said, he's obese, and also he has vomited several times. Okay, and his intake is poor, so maybe our threshold for admission will be a little low. And yes. So, and if possibly if he cannot come back to the OPD very soon and cannot follow up, or probably it'd be a good idea to admit him in the ward. So, and the next question to Dr. Aich, what are the differential diagnoses when you see, very often we see cases like this coming to us now. So what are the differential diagnoses? Can you please elaborate, Dr. Aich?
Yes, ma'am. Thank you, ma'am. The fact is that this kind of cases with fever for 4 days, with headache and body ache, with vomiting, they are frequently coming to our clinics nowadays. Keeping in mind the epidemiology of the cases or the causes of fever that are predominant or prevalent in this time of the year in our areas, I should like to first take dengue as the first differential diagnosis. Keeping in mind of that, other vector-borne diseases such as malaria, that is a very common cause of fever also, and then scrub typhus is now increasing. It is very prevalent in the rural parts of Bengal also, and also in some parts of urban Bengal at the same time. Then enteric fever has been a very endemic disease in our country for a long time, and it also has initial presentation like that boy with the 4 days of fever and headache and vomiting, something like that. And then there are some other fevers also, such as an acute viral hepatitis. In some cases also, it has some kind of initial presentation with vomiting and fever, and then later the icterus comes out. Also, in case of a viral encephalitis, initially we get a picture exactly like that. The child comes with a fever, with vomiting, with headache, and then at a certain 3 to 4 days of period, after 3 to 4 days of fever, we suddenly get a convulsion. So all these things should come into our differential diagnosis. And with that, some other features, if the child complains of some localizing signs such as cough or burning in sensation, then we can put that in our differential diagnosis also. But this is a case with a fever with no localizing signs apart from some vomiting. In that case, I just like to stick to this differential diagnosis now.
Yes, thank you, Dr. H. But yes, for the PGTs, it's very important that any child who comes with fever this particular season, we keep dengue as a first diagnosis. But please do not forget the other differential. Look for the other features. If the child is having fever for more than 6 to 7 days, think of scrub, think of enteric, look for a Eschar. Since the child is having headache and vomiting, look for meningeal signs. So these are the things we should not, in a very busy OPD also, we should not miss. Thank you. So how do we define tropical fevers? Are there any criteria, Dr. Ghosh? Can I have you on the panel?
Good evening, madam, and good evening to everybody. So the term tropical fevers is quite self-explanatory. These are a group of febrile infections that are prevalent in or unique to the tropical or subtropical regions and are collectively known as tropical fevers. They are often caused by a number of viruses, bacteria, and most often they are transmitted by insect bite or something like that. So there is we can define it like there are some essential criteria and a desirable criteria. So the fever that is defined as more than 30 degrees centigrade, and it should be at least for 48 hours duration, but with an onset of less than 48 days. There won't be particular localizing signs that will denote the infection like pneumonia, bronchiolitis, or diarrheal diseases, urinary tract infection, meningitis. However, clinical and laboratory evidences of one or more organ system, this is very important. So this will indicate towards involve one or more organ system. It may be hematological, respiratory, or circulatory, or even the renal system. And desirable criteria are one or more systemic features such as edema, rash, or hepatomegaly, splenomegaly, and encephalopathy. And as I said before, a seasonal trend may be there also.
Thank you. Thank you. So then my next question is to Dr. Mishra. What is the outpatient management of a suspected case of dengue? Dr. Mishra, please.
Good evening, everyone. Would you please share your slide? Next slide. Hello.
Can you see? Can you please? Yeah. How will you manage a case? This case, any child who is suspecting dengue in the OPD basis.
Whenever the patient is coming to our OPD, overall assessment is to be done. Should be started with detailed history taking, and the day of onset of fever is very important. Whether this patient is coming on day 3 or day 2 or day 4 like that, and any premorbid conditions like obesity, infancy, as already Ritupoto sir has told us, and any signs of dehydration and presence of any warning signs like vomiting, abdominal pain, and the watch for deficits is very important because it indicates the beginning of critical phase. And after reviewing all this detailed history taking, then physical examination is to be done. And patient regarding the rash is very much important, a sign of dehydration. And regarding management of fever, paracetamol is only medicine that is indicated, and that should be given at the 10 gram per kg 4 times daily, not more than that. And even if the patient is having more temperature, then only tepid sponging, and plenty of fluids to be taken by the patient. It should be more than the usual maintenance fluid. In case of adult, it is 5 glasses of water per day, and if it is children or infant, it should be 3 ml per hour, kg per hour at least. And at the same time, we have to try to prevent the spread of dengue by using mosquito net or mosquito repellent, and to look at the empty container that can carry water and spread dengue, and to put the window screen shut to infect mosquito, and there be spreading the infection.
Okay, thank you, Dr. Misra. So that is very important. First of all, when we think the child is having fever for 3 to 4 days, we have asked them to get a test done. And the importance is that they should come back to us, and the warning signs should be explained to the parents and the caregivers, because and the day of illness is very important for us to understand, because very often the parents think, oh, the fever has gone, my child is better. Now that is the point when all the problems start, and that needs to be emphasized. And if in some now the wards are full of dengue, some of the cases may not be able to admit. So if the vitals are stable, the child is being able to take orally, we can send them home. But the important point is to recall them. Maybe if you feel that the child is having some rash and the child may not looking too good, ask them to come back maybe twice a day. Even in the clinic, we can do that. Look at the blood pressure, look for bleeding signs, do the tourniquet test. So that's very important. And preventing the spread of dengue is something very often we neglect this. That is also very important, so that to prevent the spread. Now, the next question again to Dr. Mishra, what are the criteria for admission in a suspected case of dengue?
So if there is any comorbid condition, like patient is infant or obese patient, or taking any medications, or having hemoglobinopathy, or staying alone, this is the social issue we should think of, and staying far from the hospital facility. And of course, the associated warning signs like abdominal pain or vomiting, and any sign of bleeding or hypertension, hypotension, and high-grade fever. And most important is sudden drop of temperature that signifies the beginning of critical phase. And any organ involvement, especially of liver, and clinical fluid accumulation like ascites or pleural effusion if you suspect. And there should be our criteria for admitting the patient. And according to the severity, patient should be admitted either in general ward or HDU or PICU.
Okay, thank you. Thank you. Now, next, this child was admitted, like I said, because the child was vomiting several times, not taking oral feeds. So we admitted the child, and the initial CBC showed a hemoglobin of 14 grams, total count of 3,100, platelet of 90,000, and NS1 turned out to be positive. With sodium, potassium, urea, creatinine were all normal. Now, I think this has been dealt with, but just a quick recap, Dr. Aij, what is the sensitivity and specificity of NS1, and when should we order it?
As a dengue prevalent area as we have, as soon as we had a fever like this in a child, we should go for an NS1 as a start at a very beginning of investigation. NS1 is a very sensitive investigation, has a sensitivity of around 82.3% with a specificity of 94.3%. So it's very good. Even in neonate, the sensitivity and specificity is much more higher. So in that case, NS1, we should order it whenever a child with these specificities comes to us. In that case, we know that the child is in a febrile stage, and we can assume that there may be some critical stage or then other stages coming, and we prepare on that. Regarding the other case,
would you order PTA, PTT, LFT for this child?
Ma'am, the child has come to us on a day 4 of illness, and the child has him having a WBC count of 3,100. The child is having leukopenia. The child is having thrombocytopenia. Then we just have to need to find out what are the baseline status of my coagulation status, because that will give me the early signs that the child may be going into a dengue shock syndrome, a dengue fever.
Again, because he's an obese child, he's again has that comorbid condition. So we have to be more vigilant in doing the investigation early, right? Thank you. Yeah, so he was started on IV fluids with a normal saline of 3 ml. Since initially he was not dehydrated, so he was stable, his vitals were all right, his blood pressure was all right. So 3 ml per kg per hour of normal saline was given with paracetamol syrup and ORS, the sips of ORS that he was taking. Now, what should be the weight when you calculate fluid in these children, in obese children? What weight should you take? Dr. Ghosh? This child is 30 kg. I can't hear you. You are muted. Can you unmute yourself?
Yeah. This is an obese child, right?
Yes.
So when calculating the fluid, we should always think of the ideal body weight for that age.
So this child would be the
there
ideal
are several
weight?
methods like the Moore's method, or we can BMI calculate. We are not going into that, but the ideal body weight for that age should be always used for calculation of fluid. And the ideal body fluid that should be used is it should be always be isotonic. It may be non-normal saline or lactate solution or acetate ringa solution. And if it is maintenance fluid, we must always add 5% dextrose to it.
Okay, and we use this formula for the usual maintenance. We all are familiar with this Holiday-Segar formula. So let's not waste too much time on that.
Holiday and Segar's formula. Yeah.
So, Dr. Sinha, my question to you: how do we classify dengue, and what's its clinical significance? I think Dr. Ritabrata Kundu has gone through it, but a quick recap, please, because unless we understand that, we will not be able to manage it. So, Dr. Sinha, please.
Yeah. So, classification of dengue. Either it would be symptomatic or asymptomatic. We go to the symptomatic one, where it can be a mild or undifferentiated dengue, where it can be like any other viral fever. And then we come to the moderate dengue fever, wherein it can be like, we have to be careful. It is of two types, where it is associated with any comorbidities or in the high risk groups. And here, the high-risk groups would be like any infant, any immunosuppressed individuals, and any like anyone on immunosuppressants, and then these
any
are
congenital heart disease, any underlying
any hypertension or any other sickle cell disease or hemoglobinopathies. And coming to the moderate dengue, where there is a warning signs. So warning signs, as sir has already said, is very important. The warning signs of this we usually classify as dengue with warning signs or without warning signs. And the warning signs would
Dr.
be
Amita,
hello.
Just put up
hello
your video and say.
Huh?
It's all right. Continue.
Okay, so like the warning signs would be in the form of severe pulmonary plasma leakage, severe hemorrhage, or severe organ impairment. And these are the children which present with recurrent vomitings, abdominal pain, general weakness or lethargy, and minor bleedings, mild pleural effusions and mild ascites, or any increased hematocrit and hepatomegaly. And then we come to the severe dengue. These are the dengues with a significant plasma leak. This can, and then the dengue hemorrhagic fever with or without shock, and then dengue shock syndrome with or without hemorrhage. And then, as has been said, that expanded dengue syndrome, wherein several other organs are may be affected, like the CNS, the cardiovascular, or the renal, or the hepatic. And then it can also present in the form of abdominal compartment syndrome, where due to ischemic conditions, or the bowel gets ischemic, and then lots of fluid overdosage leads to these compartment syndromes. And then there can be severe dengue in the form of metabolites or electrolyte abnormalities. So these are gross classification of dengue.
So once the child is admitted to the ward, what are the monitoring parameters, Dr. Mishra? You're muted.
So clinically, we have to assess the patient. The vitals should be checked every 4 hourly, and hematocrits and platelet count should be done at least 12 hourly. And activity or sensorium is one important criteria for the child is alert or active and interactive. And intake output is very important, how much the patient is taking and tolerating, and urine output. This is also very much important. Minimum urine output should be 0.5 ml per kg per hour. If it is less, or if there is dry mouth or dry tongue, it indicates dehydration. And bleeding tendency should be done by tourniquet test also. Even if it is normal, it should be repeated 4 hourly. And sensorium has already been taken. And temperature vitals should be examined 4 hourly. And liver size for liver enlargement, it is also signifies underlying fluid accumulation, and onset of ascites and pleural effusion and respiratory distress. And PCB and platelets are already I have told 12 hourly at least should be taken. And Ritabrata sir has already been told that leukopenia is the first indicator of the critical phase, followed by that rise of hematocrit and fall in platelet count.
So we are all familiar with the pathogenesis, that what really happens when the plasma leak happens and the hematocrit initially increases, and that's the time when we increase the volume, and towards the later part when the fluid comes back into the intravascular compartment, we need to reduce that. So this is something we are all familiar with. So next, anything, do you know when do we suspect secondary HLH in a case of dengue? In the ward, a child Any signs that we have to be alarmed that secondary enteric is setting in?
After initial improvement, patient is having high fever and a progressive cytopenia or progressive organomegaly that is unexplained. When the patient is responding to some extent, but again patient has been deteriorated. And this time we should think of in hyperinflammatory syndrome, HLH, and for inflammatory markers should be tested then, like ferritin and fibrinogen, raised state hemophagocytosis in bone marrow, and persistent fever or fever should be more severity should be more in that case, more toxic, and hepatosplenomegaly will be more, and progressive cytopenia, and along with increased ferritin, increased triglyceride, low fibrinogen, and raised AST. And this,
so the point is, we know that fever and dengue comes down by about day 3 to day 4. But in a child who's persisting with fever, day 6, day 7, look for any other infection. There may be an enteric along with it. We have had patients with dengue and enteric together, or UTI. So look for any other focus, but definitely keep HLH in mind and do all the investigation. And we all familiar with the H score. Okay, now next question is to Dr. Ghosh. What is the protocol for fluid management in a child with warning signs? Can you go through this chart, please?
Yeah, this is a very important part of the dengue, because if we can manage this phase and we can monitor these children with danger signs, Dr. Sinha has already told what the danger signs are. So these patients should be looked at very carefully. First of all, we should obtain the baseline CBC and all the parameters so we can monitor what changes are going on. We should be able to see if they are taking the oral feeds well and if they are vomiting or not, and monitor them every 4 hourly, or if they are very ill, we can even reduce that to 2 hourly. So if the patient is not able to take by mouth and vomiting, we should start immediately with fluids. We should start in stepwise manners. As Dr. Dikaprothakundu was saying, we should not overdo it. We should do it very slowly. Remember, these patients are not in shock. We are trying to prevent them from going to shock by giving early fluid. So we should start at 3 to 5 ml per kg per hour for 1 to 2 hours, and see if their physical their parameters, the blood parameters improved or not. If they are stable, then we can step down. But if they don't, we can gradually. What we can do is increase the fluid to the next level, and we can go up to 7 to 10 ml per kg. And always at every step, every 2 hourly, we can check the PCV and see if it is improving or not. If they improve, then we can gradually taper the fluid. From 7 to 10 ml we can give for 1 to 2 hours, then reduce it to again 5 to 7 ml for 2 to 4 hours, and reduce it gradually to baseline. And then if all the parameters well, we can stop the IV fluid. But if it doesn't improve, then we go to the management of shock, features of shock.
Okay, thank you, Dr. Ghosh. So what is the key message here is that fluid management should not be the direction written in the morning and somebody comes in the evening to check the patient. It is 1 to 2 hours. A child with a warning sign, we have started fluids at 3 to 5 ml per kg per hour. Every 1 to 2 hours, we need to monitor and maybe reduce or increase the fluid. That's what the PGT is really should know about how to monitor, because that's when the child suddenly may deteriorate. And we might have to take the child, and we know how hematocrit helps us in deciding on this fluid management. I'll come to that a little later. So what are the criteria for discharge, Dr. Sinha? You have admitted this child and the child has now stabilized. What are the criteria? Are you happy to discharge? Dr. Sinha?
Okay, so the criteria for discharge would be when the child is stable, the parameters have stabilized, the child is able to accept orally, and the platelet count is okay, the PCV has normalized, the hematocrit has normalized. So these would be the criteria, obviously, when the child is able to accept orally and has no other signs of complications.
Right. And we also very confident once it's like day 7 or day 8 of illness, we know that, okay, now he's in the recovery stage. But some of the dengue cases can become bad even in the day 10. So we have to look at the clinical features and see how stable he is and then decide on discharge. Thank you. So thank you for that. We'll go to the next case 2. A 7-month-old infant has attended emergency with history of fever for 5 days. Is lethargic and not feeding well. His NS1 done outside was positive. On examination, he has cold extremities, pulse is feeble, and a systolic blood pressure of 70 millimeter of mercury. But there's no sign of bleeding, and all other system on examination was normal. Now, Dr. Sinha, again, where will you admit this child, ward or PIC?
So as has already been said, a chota or a mota patient by sir. So this is an infant, and we have to be very careful because this child can have complications of dengue. So obviously PICU would be a preferable choice, and because this child also has cold extremities, has a feeble pulse, and can deteriorate anytime. So ideally in a PICU setup.
Yes, thank you. And what is the cutoff for acceptable BP? Man, this is something, it has to be in the top of our hat, right? We cannot look at a chart to see whether blood pressure is. Any cutoff levels for systolic blood pressure in children in different age groups, Dr. Sinha?
Yeah, so this is a 7-month-old child, and like 70 would be the lowest acceptable BP. And the rough calculation of a mean arterial pressure is 1.5 into the age in years plus 55. And in the 0 to 1 month age group, the lowest would be 60, 1 month to 1 year 70, 1 years to 10 years 70 into 2 times the age, and more than 10 years, the lowest acceptable would be 90.
Okay, so thank you. I think these numbers, we have to keep it in our head. Not very difficult to remember. So why is dengue in infants? Why are we so worried? I think Dr. Kundu has talked about it, but can you just elaborate a little, Dr. Mishra? Why is dengue in infants an increased risk, and what are the common clinical features in them?
As has already been said, this is the presence of maternal antibody that babies are become more susceptible for having severe dengue, and babies between 4 to 9 months are the most severe susceptible patients, and severe dengue is common in them, and antigen positivity may be missed because of presence of maternal morbidity. And SAD has already been told, patient may present with only simple febrile convulsion and flu-like features like high fever with running nose, cough, conjunctival congestion, and GI symptom like vomiting, nausea, anorexia, and irritability, excessive cry, and diarrhea-like presentation is very much common with them, along with bleeding manifestation like bleeding gum, nose, sneeze, easy bruisability. And positive tourniquet test is not so reliable in infant because of low sensitivity. It is about 33% patients will be positive. And measly look is very much important in them. And generalized erythema with blanchable, that erythema is blanchable. So if we put finger or stetho, that impression will be seen. This is very important in febrile phase. And maternal antibody is transmitted to infant. So,
okay, so Dr. Kundu has gone through this quite well. So I think we'll just skip this slide. So we have to be sure, very aware that these children can have a kind of a secondary dengue-like features. They're very serious, they can become very serious. So any child less than 1 year, we need to admit. That's one of the indications for admission. So how does hematocrit PCV help us in helping us in fluid management, Dr. Ghosh?
Yeah. So what we have been hearing so far is that PCV is a very important guide, and that we should regularly monitor it and adjust our treatment according to the PCV level. So if we should have a baseline PCV first taken at the beginning of treatment, if it's the rise is 5 to 10%, then the rate of IV fluid in children should be 1.5 to 3 ml per kg per hour, and for adolescents it is 40 ml per kg per hour. The rise is 10 to 20%, it is 3 to 5 ml per kg per hour, and for in adolescents it's 80 to 120 ml per hour. And if it is greater than 20, then the rate of IV fluid should be increased to 7 to 10 ml per kg per hour, and rate of IV in adolescent
is
150 to 200 ml per hour. However, what we should remember, PCV should be a guide. It is not the absolute criteria. We should be guided by the clinical features also. So there could be situation where the hematocrit is rising persistently, and also look at the vital signs. If they are unstable, then that denotes that the patient is having acute active plasma leakage. We should step in, and that will need more fluid. However, if the rising or the hematocrit is rising, but the hemodynamics are stable, then that does not need any required intravenous fluid, and that be detrimental. That is extra fluid we are giving. So in these patients where the hemodynamic is stable and the hematocrit is rising, we can monitor them, and hematocrit should fall. We should expect it should fall within the next 24 hours also. And also we can have a decrease in hematocrit also And if the vital signs are unstable, then as Dr. Kundu showed on one example, is major hemorrhage we should think of, and that will need urgent blood transfusion. And if the decrease in hematocrit and the stable vital signs are stable, then there is reabsorption of the fluid. So if IV fluid should be reduced in stepwise manner, very slowly, and ultimately, if a hematocrit is normal and vitals are stable, we can take the patient off the fluid.
So we should always correlate clinically with the rise or fall of hematocrit. And what is the criteria for admitting a child in, with dengue in the PICU, Dr. Ayaj?
Yes, ma'am. We just taking it from Dr. Nilanjan Ghosh. I must start. Clinics is most important. So suddenly a child comes to us with a low BP, with a low volume pulse, and the child is in lethargy. The child is showing some sign of plasma leakage. We are also getting there was a rising hematocrit. There was a falling platelet. So these are the signs when the child is in so signs of severe plasma leakage. So with hyperperfusion, that was the first indication, and the commonest at the same time also. And we also after more aggressive fluid therapy sometimes may lead to fluid accumulation in the later stage and the recovery stage. So in that case, we can get enlarged liver. The child is having respiratory distress with the basal crepitations which are coming out. The child is looking a bit more edematous. So in that case, that was also another indication of admitting the child in PICU. Then if the child has coming to us with a sudden drop of PCV and the sudden deterioration of the child, and we that may assume that that may be a case of a severe bleeding or a sudden concealed bleeding, as Dr. Kundu has told in our previous lecture. So that was also an indication. And we have to look at very, very crucially at the signs of organ derangements. So sudden onset tachycardia, and we find the cardiac enzymes elevated, myocardial dysfunction has set in. We can determine by also bedside echocardiography. That is an indication of admission. Acute kidney injury, sudden rise of the urea creatinine values. Low urine output, as we are measuring the urine outputs. Then altered sensorium with the Glasgow Coma scale coming down 8 or below that. Hepatic dysfunction with the AST rising very sharply, and the sign that the child was initially was improving, then suddenly there was a severe deterioration and there was a very persistent fever. We can also think of HLH. So these are the indications when we should admit the child. So it's criteria of clinical and the investigational both come hand to hand. So then we can admit the child.
So in summary, we should suspect dengue in all cases of fever during this present season. Recall of OPD patients is very important, and that should be done more frequently, maybe even twice a day. Early recognition of risk factors and prompt management. Monitoring by the bedside is the key to good outcome, and prevention of fluid overload is very important, because now that algorithm says 5 to 7 ml per kg per hour. So that needs to be monitored. We cannot just leave the patients. Every hourly, we need to monitor that patient. That is very important. So what are the do's and don'ts in dengue? Do tell outpatients when to return.
Sorry, madam, you have 5 minutes more. Okay.
Yeah, I'm just finishing. This is my last few slides.
Yeah.
So do tell this is just a summary slide. Do tell outpatients when to return. Do recognize the critical period. Closely monitor fluid intake and output. Vitals should be monitored. Hematocrit levels in intake output, like we just mentioned. Do recognize and treat early shock. Early shock is characterized by narrow pulse pressure. That has to be monitored. Do administer colloids. I think in the PICU session, we'll be talking more about that. Give PRVCs when you think there's bleeding, significant bleeding. And don't give platelet transfusion, like what Dr. Kalpana ma'am just said. Just give whenever the platelet is low, give platelet, because we have to understand that there's a chance of fluid overload. Don't give half normal saline, like 0.5 and 4.5 normal saline. Don't do any harm to these children. And then don't assume that IV fluids are always necessary. So with that, I thank all my panelists, and I hope I am stuck to my time. These are my sources, and thank you for your kind listening.
Thank you, ma'am.
Yes, thank you, ma'am, and the whole panelists for very lively and very practical discussion on how to manage the patient in OPD, when to admit and when to discharge, and how to tackle the fluid. That's a very day-to-day question that we face in our practice with the dengue. And there are a few questions in the chat box. I think if I will request the madam and all the panelists to answer in the chat box, because we are already 15-20 minutes late. I think from the next time we have to keep the dengue a whole day program. Otherwise, it will be always
or 2 days program, or 2 days program, not in 1 day. Okay, good.
Yes, so moving to the next session. So after the OPD and the IPD management are relatively a stable child or a child with warning sign are going to the child with severe dengue who needs the ICU care. So to continue this discussion, we have a panel discussion here. So moderator is Dr. Ognishekar Saha. I think all of you know him, Dr. Ognida, as the consultant at the PICU of Apollo Multispecialty Hospital and the Institute of Child Health. And he is everyone in pediatric emergency and ICU knows Ognida in West Bengal and all over the country. So over to you, Ognida, just introduce your panelist and go ahead.
Sure. Let me share my screen first. This must be it. Yeah. Is it showing?
Yes.
And I am audible. Of course.
Yeah.
Yes, you are always.
Yeah. Thanks to the organizers and welcome to the last session. And here we'll be talking about ICU management. My panelist, Mihir, who has just introduced me, and everybody knows Mihir. He is in doing fantastic work in the government sector. And then Dr. Prabhas Prashan-Giri, again, very beloved junior, who is running the PICU very commendably in ICH. And then Dr. Priyankar Pal, who is my batchmate, again, one of my very close friends. And Priyankar is here primarily as a rheumatologist and for his contribution in the management of HLH, which we'll cover. And then Dr. Shotobrata Rai Chaudhary. Shotobrata, I don't know in which hospital you are currently at the moment. But
I'm working in SSKM Hospital in PG.
SSKM, right. And but Shotobrata has been again working in the government sector with a sort of very focus on intensive care, and he has been doing this. He has been with us for quite a few years. And then Dr. Shomenda is the most senior among all of us. And he's leading the PICU in AMRI Mukundapur again for quite a few years. He's a very senior person. If I'm confused and I need some advice, I often pick up the phone to call up Shumin.
Thank you.
So why is it not moving? And it is not moving. Maybe because what?
Right click, make a right.
Right click.
Next.
Do I need to do that all the time?
No.
Yeah. So a bit of an overview. So we'll cover severe dengue and its progression and variants, focusing on management rather than pathophysiology and theory. We'll cover some areas of confusion and debate, and that's primarily regarding the HLH management. I hope we'll not bore our audience with that. And it will be more of a freewheeling type of discussion. We're all very close, and so it will not be very sort of, structured sort of thing. So let's start. So our first case is a 5-year-old boy, weighs 35 kilo, quite a hefty kid, and he has got a previous history of dengue. Is admitted. He was NS1 positive on the 3rd day of illness, as was done by his general pediatrician. And he was also antibody positive on day 6. He has been afebrile on day 5, from day 5, as is expected. And today is the day 7 of illness. So we are on day 2 of afebrile illness. And he has been receiving fluids at 3 ml per kilo per hour, which comes to 54, because the pediatrician has calculated the fluid as per his estimated ideal weight rather than his true weight. Okay, so it comes to 54. And if he goes by his true weight, then it will be something almost double than this. So that's what he's getting. His last PCV was 38. That was done day before yesterday. His blood pressure currently is 90/70 with a mean of 70. 90/60 with a mean of 70. His heart rate currently is 145. He's cold centrally and peripherally. His peripheral pulses are feeble, but central pulses are okay. He's breathing all right. He looks quite lethargic. Now, what one information is not here that you would like, and what could have been better in what has been done so far? Let's start with maybe Shottabrata. Shotta?
Hello,
Yeah.
am I audible?
Yeah,
Okay.
you are.
So the child is not hemodynamically well. It is evident from the history that child is not hemodynamically. Hello.
Yeah, you are
hemodynamically
audible.
Yes,
well.
yes.
There are
Okay.
many another sound is coming. Okay, Satyapal.
Okay. Okay.
Go on.
So the child is in afebrile phase of dengue, which is a critical phase of dengue. So there is a high chance of fluid leak, and the child is, or from the clinical picture, the child is leaking fluid. So the most important thing is I want to know about the urine output and the water intake of the child. The child was in 3 ml per kg per ml fluid, and it was on maintenance fluid. So what was the urine output? That has to be mentioned in this picture. And the second question was,
And do you think that we should have, so urine output, as you rightly pointed out, is something glaringly absent here? And is among things, you know, is there anything that should have been a bit better? His last PCV was done day before yesterday.
yeah, PCV has to be monitored very frequently. And another thing is that if you're, we have to titrate fluid regularly. Just keeping 3 ml per kg per hour fluid for a long time is not enough for managing dengue. We have to regularly monitor and titrate the fluid accordingly. I want to emphasize on that.
So, yeah. So basically, you know, one thing is urine output is a fantastic guide, and it costs nothing, but you need to put in a urinary catheter to get that. And oftentimes, you know, if your kid is not that unwell, you may find some resistance either for the patient or the family. But if you are worried, just overcome that resistance. Put in a catheter. That gives you peace of mind. And doing a PCV day before yesterday, that's not good. So what steps would you take immediately? What would you monitor, and how would you monitor them? Maybe Prabhash?
Yeah, good evening all. So if you go to the history, there are first two very important points. That is, the child is obese and the dengue for the second time. So these are two the very risk factors. And on that, if you are going to the clinical phase, the child is on compensated shock. Is maintaining the blood pressures, is tachycardic, the peripheral pulses are feeble, breathing okay but lethargic. He had last PCV 48 hours back. We don't have any baseline PCV at this moment. We don't know about the urine output. So definitely two things that I need to do at this moment. I need to put a Foley's catheter. I need to take a hemoglobin PCV platelet. If possible, I need to do a gas. If venous is good enough to see the lactates and see any base diseases or not. And depending upon the urine output, the PCV and other clinical parameters, I would like to monitor this patient. Definitely in the PICU setting.
Fantastic. So, take-home message, as has been already said, beware of risk factors, as Prabhash has said, monitor closely, especially the first 3 days of afebrile period. That is when they mostly go wrong. The first 3 days of the afebrile period. Urine output is fantastic, but you need a catheter. And early in the course of the disease, if there are features of hypoperfusion, as this kid has, be absolutely liberal with your fluids. That's fine. One thing I would say that this ml per kilo per hour business, I find it a bit difficult, because suppose I've got a 10 kilo kid and I'm giving 4 ml per kilo, then I'm just giving maintenance. 4 ml per kilo is just maintenance, right? On the other hand, if I've got a 50 kilo adolescent and I'm giving 4 ml per kilo, then I am giving twice the maintenance. So just 4 ml per kilo does not really tell me anything. I need to know what is the actual weight of the kid. And then what would be his usual maintenance, and then 4 ml per kilo gives me something. So beware of this. You know, you always go by ml per kilo, go up to 6, go up to 7. 6 ml per kilo for a 10 kilo and 6 ml per kilo for a 50 kilo are hugely different. So that's another thing. So the case continues, and we are 10 hours down the line. He's now on 144 ml per hour of IV fluid, which comes to something like 8 ml per kilo of his ideal body weight. He's now needing nasal cannula oxygen at 2 liters per minute with some recession. Peripheries are warm, sensorium is alert, blood pressure is 100 by 55 with a mean of 70, which was right. Is it 70? Should be maybe a bit more than that. Heart rate is now 100 per minute. The BP initially was 90 by 60 and the heart rate was 145. Urine output for last 6 hours is 0.8 ml per kilo per hour. 0.8 ml per kilo per hour. What did you do now and why? What one important information is missing? Mihir, please.
Yes, thank you, Ognida. So basically, before going to this question, so first of all, as Prabhas has rightly pointed out, the patient is in compensated shock. So before giving the fluid, this patient, I would definitely, as the patient is already admitted or maybe the referred from another hospital. So the if the patient has already got any bolus or not, so what type of fluid it has got, the crystalloid or not, and how much bolus if it is child has already taken any bolus. So that will be very important, because if you need to give another bolus or another in this patient, we have to titrate. If the already patient got the more than 20 ml per kg of crystalloid and then patient is still compensated shock, then we have to think about the colloid at this present, and also as based on the hematocrit, if the blood transfusion record, that is already discussed. But coming to this present scenario is that as you have rightly pointed out, the monitoring, the things that you have to monitor regularly in dengue patient as the blood pressure and with the pulse pressure and your urine output and the hematocrit and the capillary pulse volume and the refill time. But we have to keep a very realistic goal to the patient. So our blood pressure target should be just more than 5th centile for this age of this patient and the sex of this patient, and the pulse pressure should go, if it is the narrow pulse pressure should improve and go to go above 30. Urine output target should be just more than 0.5 ml per kg per hour. Whenever the urine output is going towards the 0.1 ml per kg per hour and the blood pressure is high, if we're going to the 50th centile, then we are overhydrating the patient and we are giving the more fluid, and that is has its own complication, and that may lead to fluid overload and the bleed, even that may be the one of the cause, even the bleeding event. So that is the so at this point of time, we have the patient is blood pressure has already targeted, urine output is 0.8 ml per kg per hour, and the patient is getting fluid of 140. That is too high. That around is coming, I think, if you say it is around 8 to 10 ml per kg per hour, if we go to the ideal body weight. So we have to immediately dial down the fluid. We have to check the hematocrit. We have to again check the urine output hourly in this patient and monitor the blood pressure and the pulse pressure. So these are the things we have to do. And important information, that is if the patient has developed any respiratory distress or the tachycardia has developed, the tachycardia patient has settled down, the heart rate is now
the heart rate has come down actually, yeah.
Has come down, yes. But
we don't have the PCV, isn't it? I mean, we don't have the PCV.
Yes, we don't have the that we need to monitor every 2 hours at this point whenever you're titrating the fluid in this patient. Yes.
And is there one thing in this patient which would make you a little bit worried and will even drive you more to reduce fluid in this patient? Something developed which will make you even more worried, and they will say, I must reduce fluids now. That he was not needing any oxygen.
Yes. So if the patient has some recession is there in this patient, if the respiratory rate is increased and that the patient has got requiring oxygen and there is chest retraction is there. So that is the earliest sign that patient is developing some fluid.
Absolutely. So the take-home message is tracking of fluids is very, very important. And maybe even more important than giving proper fluid. That's what we have learned over the last few years. So once your pulse pressure widens, and your heart rate settles down and your urine output is increasing and your PCV is coming down, then you need to back off, especially once the respiratory, once they starts needing a little bit of oxygen. That means a pulmonary edema is setting in. that's the time you have to back off. The other thing is a lot of people may say the urine output is still not 1 per kilo per hour. Remember, it is 0.5 to 1. And especially for obese kids, for small kid, yeah, 0.5 may not be good. For small kid, for obese kid, 0.5 is good enough. And this is a kid who is hefty, who is obese. Okay. For this kid, don't stick to, it is still not 1. So I need to give more. No. It is 0.5 to 1, and for obese kid, 0.5 is good enough. Now, that was one world. And in another world, the same kid, 10 hours down the line, is still on 144 ml per hour. The same kid is still on 144 ml. And he's still needing nasal cannula oxygen, 2 liters per minute with some recession. So the first 2 points are the same, but the other points are a bit different. In spite of getting that much of fluid, his peripheries are still cold, but he's centrally warm. His sensorium remains tired. His blood pressure now is 85 by 55 with a mean of 65. His heart rate is 148. The blood pressure previously was what it was. And urine output is 0.3 ml per kilo per hour. Are you happy? What exactly is the problem? This one for Shomendra.
Thank you, Agni. Good evening, everybody. No, I'm not happy, obviously. What exactly is the problem? Obviously, we need to find out. But obviously, you're not happy with the hemodynamics. The blood pressure is still low. The child is tachycardic. I'm very worried about the sensorium now. The child looks tired. So in old terminology, uncompensated shock, we are not using those terms that much these days. But this child obviously has not been resuscitated. So this is somebody I'll be very concerned about. And the other thing I wanted to say is that the dengue management guideline is primarily for children in the ward and not necessarily can be strictly followed when they come to PICU, because we have got more monitoring devices and they have their utilities, and we just can't depend on PCV and urine output and things like that. So there are the other ways to monitor this child. This child probably should not have come to this place in the first place. So obviously child is under resuscitated. If the child hasn't had any colloid, then I'll think about it. And what exactly is the problem? It may be the capillary leak the child is having. We are not on top of it, so we are not keeping up with the fluid. And I'll also think this is probably more than 48 hours down the line. So you need to start thinking about the other complications of dengue, like secondary infection.
We'll go there later.
HLH.
We'll go there a little bit later.
No,
so in terms of physiology, I mean, where is the, I mean, this is the critical thing, that there are a bit is showing signs of overload and then bit of hyperperfusion possibly.
Yes. Yes, so this is the worst of the all worlds. So this child is obviously in overload because there is respiratory distress with oxygen requirement. The child may be solid by this time, but the intravascular compartment is still inadequately filled. So that is the problem here. And what we do about it depends on what exactly has been done before that. So that if the child has, it looks like the child has not been resuscitated adequately, right, we may have room to give more fluids. If the child has had too much fluid, we have got other options to think about. But this is something where colloid is something we'll think about if the child hasn't already had the colloid.
Sure. So this is the very, very important slide, I think. Again, perfusion is paramount. You have to perfuse well at all cost, So that is always there. But when you have already features of fluid overload and the kid is still not perfusing well, these are the kids who will go downhill, right? And this, if there is one take-home message from this entire presentation, especially for those people who are working in the peripheries, once you get this combination, this is a deadly combination. These kids will give you grief. These kids will need a lot of intervention. So if you have already not sent the kid, send this kid by now, because it may be already late. If you stick longer, it will really be late. So once you have got this combination of hypoperfusion with fluid overload, and you are not sure that you can manage this kid, then please send them now. Otherwise, we'll end up with a bad outcome. Right.
Something just want to add that this is a combination. When we have given lots of crystalloids, we overloaded the patient with the fluid, the patient is still intravascularly volume depleted. But sometimes it might be difficult to assess the intravascular volume, whether the patient is underfilled or not. I think a serial blood gases with lactate may be helpful for these sorts of patients. To determine
we can do a lot of things, Provash. But the thing, my main message is mostly to people who are working the outside, who are not in. And then my main message is, if you see this, then don't keep them in peripheral centers. Send them in, right? So once you have got it and now you're in the ICU, what are your options? What can you do about, what are your options? What can you do? Who should take this question? Maybe Mihir?
Yes. So
what are your options in big categories? What are your options?
Yeah. As Soumendra has rightly pointed out, that whenever the patient is coming in ICU or this type of severe patient, patient with severe dengue, who is at the same time volume depleted and leaking profusely. So these are the group of patient who is going to be very complicated. So besides this, what maybe we have to think about constantly in our mind. So what could be the possible causes of this patient not persistently unstable hemodynamics? It may be this persistent leak. It may be the bleeding, that is concealed bleeding, that already has been discussed. So your Paxil hematocrit value will help you here if you monitor it serially. And you have to also think about the other causes at this present that we can monitor in ICU or in a setup where it is available, like if the patient may be associated with other issues like the myocardial dysfunction at this moment. So that we need to monitor this patient bedside echocardiography and the measurement of the IVC diameter and the collapsibility will help. And also if there is already B lines in the lung, or lung is clear, that could be a helpful one. Another thing that we have to keep in mind, when the patient is leaking and we need high fluid, then the patient having huge ascites, that may lead to the abdominal compartment syndrome. So there will be the return of the venous return will be low. So the patient, even we give the fluid, the patient will not be perfused, and there will be hemodynamically unstable persistently. Even the urine output very low, as the renal perfusion will be less because the intra-abdominal pressure is increased. Other things, the sepsis, as already mentioned by the Soumendra, that's we have to keep in mind. Electrolyte imbalance, hypoglycemia, if you're giving too much of the crystalloid, not giving any glucose to a small change in the hypoglycemia is another cause that may lead to the hemodynamic instability. So at this point, that we have to think the various possibilities, and we have to judiciously use the patient physiology at this point and available investigation, and have to take the decisions.
Right. Yeah, I don't think I'll add anything to that. Now let's talk.
Just wanted to point out, sorry,
yes,
just
Soumendra,
wanted just wanted to point out one thing, is that the inotrope we didn't discuss. Generally speaking, people are very afraid of using inotropes in children with dengue, because people feel that this is essentially a problem with hypovolemia because of capillary leak. That's the primary mechanism.
True.
But we are not trying to make these children euvolemic intravascularly, because that may not be achievable, because the more crystalloids we give, the capillary leak may increase with the excessive volume. The glycocalyx may wash away further. So I think there is a place for inotropes, especially vasoconstrictors, if I'm not worried about the myocardial function, which would release volume from the capacitance vessels, like noradrenaline, can be helpful, because trying to make this patient euvolemic is possibly counterproductive at this stage, where the child already has had quite a lot of fluid, and the more fluid we give, we are actually essentially worsening the capillary leak. So I think we should be a bit, obviously judiciously, but should be considering about vasoactives like noradrenaline in these children, and try not to correct the hypovolemia.
Absolutely. And
Completely.
in terms of nature of fluid, I think possibly we'll have a consensus that by this time, possibly most of us will change over to colloid rather than stick to crystalloid. Is it not? Anybody would like to differ?
No.
No.
No, I think there is a consensus by now.
So
that
possibly by
colloid would
it's
be
time
preferred.
to move over to colloids, time to assess your intravascular volume status. As Shomendra said, it is not inotrops is a no-no. It can and actually is often used. And then you'll need to think about, whether there is a concomitant sepsis. So we'll invariably give them a broad spectrum antibiotic. You'll always do that, even if there is none. And then you'll need to look at the cardiac status. You need to think about abdominal compartment syndrome in some of the cases, especially if your urine output is low. And then it is a dynamic thing. You cannot really cover the entire bit. It's impossible. So let's talk a little bit about bleeding. So I've got two cases. Case one, day 7, needed 120% maintenance fluids for about 24 hours. Now back to maintenance. He's got a good urine output. His PCV is stable. His LFT is almost normal. And his platelets are 12,000, right? And we've got another case who is also on day 7, who is now on 160% maintenance fluids. His urine output is still just about hovering borderline, somewhere around 0.8 to 0.7, 0.8. He's still on inotrops. He's acidotic. His lactate is 4. His PCV is still high. His LFT is deranged. And his platelets are 22,000, 10,000 more than case 1. Which patient is more likely to bleed? And why? Why is that so? Shotabrata?
Yes. So we know that in dengue, really platelet count doesn't correlate well with the bleeding. It is more about the soft acidosis that determines the bleeding and coagulation dysfunction. So though the platelet count is low in case 1, most likely it will improve if we wait. So if the child is improving, so platelet count can also improve. But in case 2, the child is deteriorating. The child is still in shock. Child may have coagulation dysfunction and child may have the acidosis. So that will lead to more aggressive bleeding. So that is the important to understand. So platelet count is not determinant for bleeding in dengue.
Right. And it's also the hypoperfusion, which can cause endothelial injury. And that endothelial injury is again a big part of the big part of the whole scenario, isn't it? So coagulation, what is your coagulation doing? How healthy is your endothelium? And then what is your platelets? It's not just the sole platelet, isn't it? Yeah. So the more sick the kid is, the less well they tolerate a low platelet count. Yeah.
Yes. That is the reason.
Yes, absolutely. So in a kid who is otherwise healthy, otherwise looking good, he will tolerate a low platelet count much better.
And we can wait.
Sorry?
We can wait in that child. If the child is monotonically improving,
exactly.
Then we
in
can
case
wait.
1, we will wait.
Platelet count, yes.
Sure. And then besides the platelet, especially in this kid, what other parameter would you like to check if already not checked? Maybe Prabhash? What other test you would like to know, information you would like to know, or at least you will send off the test if already not done. Prabhash.
Bleeding in severe dengue is a multifactorial. Thrombocytopenia is
he has not bled yet. This kid has not bled yet.
So in these patients, both the two, basically case number 2, we need to check the coagulation parameters urgently. We need to check the INR, APTT, and do not forget to check the fibrinogen. The patients with a deranged liver function has more chance of having a coagulopathy, and PTN or APTT will be helpful. Not only that, you need to check it in a regular interval, and as well as you need to check the fibrinogen. As low fibrinogen is there, more chance of bleeding is there. So depending upon the fibrinogen, you need to check, and depending upon the bleeding, we need to think that what blood product you need to administer to this patient. If your fibrinogen is significantly low, then it's better to go for either a fibrinogen.
Stop it there. I've got a separate question for that. Right. Okay. Please go ahead. Yeah. Right. Yeah. And then besides the coagulation, any other organ specific tests?
Definitely. I need to check the LFTs.
You need to check the LFTs. Absolutely.
One thing I
So
just want to take a point is the this hypothermia. If the patient is hypo, that is another risk factor for bleeding as well. So this acidosis, hypothermia, this is the lethal triad: hypoxia, acidosis, and the hypothermia. So we have to also think about that. If the besides this coagulation profile and the acid
absolutely,
persistent acidosis,
especially in small kids, isn't it?
Yeah,
Especially in small kids. Right. Yeah. So Provash has spoiled the game a little bit, but yeah, let's go ahead. A patient is bleeding from the mouth, ET and NG. Platelets are 12K. You have already given 9 units of RTP. What are your options in terms of platelet? Very simple question. Basic, Shomenda, easy question. I mean, we have given plenty of RTP, and you are not winning. Your platelets are still low, especially in this part of the country. Yeah.
Yes. As it has been discussed, that the etiologenesis of bleeding in dengue is multifactorial, and platelet number probably has the least to do with it. It's about the platelet function and about the endothelial dysfunction that we see with, especially with acidosis and shock and hypothermia, as Mihin just mentioned. So my options are, Ross has already gone through this. Fibrinogen I need to check, because I can't stop bleeding if my fibrinogen level is not within an acceptable range, because
I'll again interrupt you there. I still want to increase my platelet number. I have been giving RDPs, and it's not helping me.
Okay, so my next option would be to go for SDP.
Yeah,
single donor platelet. Difficult to get these days, but in this situation we need to really try to get hold of SDP, because RDPs are not helping, and the platelets are essentially being destroyed. Whatever we are giving is not in the circulation for any length of time, so SDP will have a higher chance of staying in the circulation and stop the bleeding. So yes, SDP would be my first reference, and fibrinogen obviously.
Exactly. So SDP may not be widely available, but if you are really struggling to bring your platelet count up, I have seen RDPs. I think the RDP qualities are not very good. Often they are not very good. So SDPs, they often really help, but yes, difficult to get hold of. And then again to Shomenda again, and your coagulations are deranged. You have given FFP and he's still bleeding. This scene, Provash has already stated, but still, what will you check for? And then if it is low, how will you treat it?
Fibrinogen is the thing to check, obviously, and if it's low, the thing that I would do in the first instance is give them cryoprecipitate. Again, it can be difficult, especially out of hours. It's difficult to get hold of cryoprecipitates, but we should really try to get cryoprecipitate, because that will have some FFP in it. Otherwise, some fibrinogen in it. Just giving FFP is not really helpful. That doesn't have the any significant quantity of fibrinogen. So cryoprecipitate is the thing that we need to look for, and that should.
And is there any particular fibrinogen level that you would like to sort of reach and maintain?
Fibrinogen problem with fibrinogen is labs code different values. The one I use normally is more than 150. 150.
Yeah.
Thereabout, but
yeah.
lab parameters are different.
Sure. And there are some companies who are coming out with this fibrinogen concentrates. Fibrinogen concentrates. They are very expensive.
Very expensive.
I don't think they should replace cryo at all. They have an advantage, is that their volume is low. So if you are really tight for volume for some reason, then they may be. The other thing is, if you have it even at the middle of the morning, even at the 2 o'clock in the night, if you have it, then you have it. So availability may be an issue, but they are very expensive. But they are available. Yes. They are there now. Yes. So that's it. I see. Let's move over. So we've got another twist. A 5-year-old kid with secondary dengue on day 8 received up to 150% maintenance fluid and still needing it. and on inotropes. Fever is persisting. So day 8, fever persisting, inotrope need persisting, still on inotropes. What are your thoughts? What are the differentials? What investigations would you send? Who will take this question? Mihir?
Yes, so that is the tricky. So this is the patient is over this is a prolonged critical phase. This patient already on day 8, but the fever is persisting and patient requiring still not hemodynamically so stable. So at this point, we have to also think about if the patient have this already secondary, we have talked about the secondary infection. Then we have to also think about the other causes of the fever at this, because there's the other tropical fever like the enteric fever, leptospirosis, scrub typhus associated, because many a times we get the mixed infection that complicate the situation, and these are the things we have to rule out, and so the serological test should have been sent for that. And of course, then we have to think about this dengue associated secondary HLH or the hyperferritinemia or the cytokine hypercytokinemia at this stage, whatever the terminology we use, but they may not be fit always the HLH criteria, but it is maybe that prolonged hypercytokinemia that is maybe leading to the high fever and the persistent hemodynamic instability. So we have to send the investigation like ferritin, we have to send the other look for the CRP if available, the procalcitonin, and the other parameters like the LDH, the fibrinogen level already we have talked about. So and the triglyceride level. So these are the investigation we will send.
Right, sure. So we need to exclude other investigations, as Mihir said, all cultures and then other tropical infections maybe, and then these HLH markers, sometimes we call it HLH panel. And that was sent, and your hemoglobin is 7.8, which is low. Your TLC is 2,200. Your platelet is 32,000. Your CRP is 135 with a cutoff of 5. Your procal is still 0.2, not much. Your ferritin is pretty high, 15,000. Your triglycerides high, 320. Your fibrinogen low, 110. Your LDH is high, 575. So this brings us to the dreaded term HLH, right? So this is the thing. This is the, I think, well-known HLH criteria. Now, dengue can cause HLH. With this, again, Priyankar comes in. Priyankar, give us a, very brief sort of, some maybe overview about infection associated HLH vis-a-vis primary HLH. Brief. Yeah.
Majority of primary HLH, if you say, or the familial or the genetic HLH, they will present usually in infancy. But again, definitely we again know that a lot of secondary HLH which present later may have a primary component also. So age, definitely, if the presentation is in infancy, we will definitely think of a primary HLH initially, number one. Number two, now a lot of people say that all HLH, why is the child going into HLH? So there must be, so everyone is not going into HLH. So maybe there are some components of genes that are still undetermined, or we still do not know, where you may be having some underlying immunological problems, and that is why you are actually going into secondary HLH. And so that's a debatable area, of course. But again, definitely the treatment. If you feel you start treating, you send a genetic panel, which is again a little expensive, definitely, but worth doing it. So, but again, actually, there are no definite guidelines without a genetic panel where you can really differentiate between a primary and a secondary HLH. But what we have observed over the years, that if it is a secondary HLH following a systemic inflammatory disorder like a SJIA, systemic juvenile idiopathic arthritis, where MASH is almost a part and parcel of SJIA, so they will have very high ferritin. But in secondary HLH, or especially in primary HLH, the ferritin level is not that high. It's not that. So, but again, it's a very, very sort of, it doesn't help really in clinical practice.
Right. And also, I mean, in terms of primary HLH is a recurrent disease, isn't it? I mean, if they,
Definitely.
yeah. So if they are, and if they survive one episode, they'll come back. They keep coming back until they die almost, or they get a bone marrow.
Without a bone marrow transplantation or a so they will have relapses. So recently we had a baby. So baby proved primary HLH. So we gave etoposide to that baby from the very beginning. The entire HLH protocol, the baby came out of the HLH. So presented at 1 month of age, the baby came out of the HLH, and again after around 5 months, the baby again went, and this time
that's the rule. I mean, for primary, that's the rule. They will keep coming back until they die, unless they get a bone marrow transplant. Whereas these secondaries, once they get better, they don't recur, and they happens all over the age group. Whereas primary, mostly infants. Yeah. So how common is dengue HLH? Some studies, adult study, Malaysia, we're running short of time, so I'll run a bit fast. Say a pretty decent number of cases, 180 cases, about 40%, about 40% had HLH of the total 180, of the 77 who were evaluated. And of that, 40% died. And that is way more than the overall mortality of 22%. So it's about 40% of the entire severe dengue and having a higher mortality. This is an Indian pediatric data from PGI. Severe dengue, 22, of which about 1/3 had HLH, right? 1/3. And again, about 30% of them died. And actually, just out of 7, 2 kids died, and 4 had steroid, all survived. 3 kids did not receive steroid, of which 2 died. This is from PGI. And this is some local data. This is from ICH. Actually, 2 of the authors, Priyankar and Provash, are part of this panel. One of the very early, 2014, pretty early, a case report of 8 dengue cases with HLH. They have fulfilled the HLH criteria, and all they needed is just a 4-week short course of steroid. None needed any organ support, and they all survived. So it's varied. So when should we suspect HLH? I think we have already said. So your kid is sick looking, he's in developing multiple organ dysfunction, he's not improving, he's got bicytopenia, CRP high, maybe splenomegaly. So what to do? You send your HLH screen and maybe plus minus bone marrow. Again, bone marrow. Will you routinely do it? We'll take that question. Shominda?
No, I wouldn't routinely do bone marrow because hemophagocytosis may not be evident in the bone marrow, and just not finding hemophagocytosis is not which is not going to rule out a diagnosis of HLH. So no, in these children, I don't go for bone marrow. These days, I have started using H-score more because the problem with the 5 out of 8 criteria is one of them or maybe 2 of them are not routinely checked. Soluble CD25 is absolutely impossible to do, and bone marrow, complicated procedure. So if you are choosing 5 out of 6, then it's bit more complicated than 4 or 5 out of 8. So I tend to use H-score more these days, which gives you a percentage rather than a yes/no answer, and then you can think about the whole scenario and do whatever is you think the best for the patient.
Just to comment one thing that if you forget about the term about the HLH, we intensivists usually see 2 types of hyperferritinemia and dengue. One type is typically the fever is continuing 7 days, 8 days, 9 days. A bit of capillary leak is continuing, or there is a new onset fever, new onset hepatosplenomegaly, new onset cytopenias. Patient is not improving, but not that sick, ventilated, multiple ionized probes bleeding, not that. If you are sending everything, every excluded, your ferritin is high, it is HLH. But we more commonly see our patients, afebrile for 12 days, came in a severe shock with MODS, no fevers, no splenomegaly, no new onset cytopenias, afebrile with a very high ferritin of 1 lakh, 1.5 lakh, that bad. So they are not fulfilling the HLH criteria. They have no splenomegaly. They don't have any fever. They just came with a severe shock, organ dysfunction. You have sent the ferritin came to be 1 and 1.5. The first case scenario that you have shown, we have no doubt that's the HLH. We need to treat at HLH. But what should we do in this sort of patients? Came in a MODS, came in a shock, no new onset fever, afebrile for 24 hours, had no new onset cytopenias, and
that's the hyperferritinemic thing. No, that's the typical hyperferritinemic thing you are talking about. We will sort of cover that. We'll sort of cover that. So let's just give the important messages first.
Nida, we have 5 minutes more. We have to just
only. Yeah, I know. This was going to take time. So one important message that must go out is, look, even if your HLH panel is okay, it is sort of positive. It is just positive. But if your patient is not deteriorating, you may wait and watch. You may still wait and watch. And many a time, even if you do not do anything, it may revert. You do not always need to treat it. If deteriorating, especially developing organ dysfunction, then you need to do something about it, and time is of essence. And initial choices are steroid or IVIG. And here I think there is no doubt. I mean, no difference of opinion. So steroid, dexamethasone or methylprednisolone. Again, I'll direct this question to Priyank. So you will agree that you will start some steroid, isn't it? So which steroid and why? Priyanka. And what does? Duration.
Ogni, it is not only often time is important. It is the most important thing. So what I have realized over the last maybe 15, 16 years of treating MAS, HLH, now what we call a cytokine storm syndrome, the most important thing is the timing. The time that you intervene, the time that you intercept that storm. So that is the most important. It is not the drug that you are using, not the dose that you are using. It is the timing. So the most important is you recognize early and give the medicine. What we have usually done is a dexamethasone. So the classical standard protocol of 10 mg per square meter of dexamethasone in 2, 3, 4 divided doses. Sometimes we have used, yes, methylprednisolone, where the ferritin is very high. So if you have a child who's coming with a ferritin of 1 lakh, definitely I'll pulse that child with methylprednisolone.
Pulse
so
means
that
you'll
is,
give study.
then again, the time that you intervene, what is the clinical scenario, how sick the child is. So a lot of issues are over there. The drug that you are using, and again, the dose of the drug that you are using.
Right. And for how long? The steroid for how long?
Yes. Yeah. So if you refer to our initial study of that 2014, so over there, I think we used steroid for 4 to 8 weeks. But what we have realized over the years, that again, it is the timing and not the duration of steroids. So once that
we have got
you can
that
switch off that thing.
So how long will you continue?
Timing intervention. Yeah. So maybe 5-7 days. So once the patient reverts back, you don't have to continue. You stop it by the 5-7 days. So it's not a long duration of therapy. It is a
right.
timing.
And what
again,
will be your marker? Which will guide you? What marker will guide you?
So everything. So it's definitely the patient, the clinical parameters of the patient, the blood counts, the platelet count. The platelet, when we treat CSS, the platelet is something which is the first to improve. So the platelets, the ferritin, so everything will be taken into account.
Right. So an overall,
and one more thing,
overall clinical observation, and then the ferritin and the platelet. Right.
Exactly.
Right. And then IVIG. When do you use IVIG in these patients? Shobinda?
IVIG is not my first choice. If I am thinking somebody has got HLH, I would go for steroid. If I have got concern for sepsis, I probably would treat the sepsis and still give a steroid. I don't frequently use IVIG for the indication of HLH, but I have used it on a few occasions when I think after giving steroid, dexamethasone, usually I don't see the response that much. That's the time I have used IVIG. There is no evidence that one is better than the other, so I wouldn't say my decision is evidence based, but I have used it in those situations, but not as the primary agent to treat HLH, and cost is obviously is an issue.
I would love to take others' opinion on it, but we are running short of time. So this is the area where actually we should have more discussion. And almost always, so treat for sepsis, let's just go ahead. So dexamethasone and then plus minus IVIG, no doubt. Some kids will not even do better on there. Some kids will still keep deteriorating. And it is this group of patients where it is absolutely not sure what is to be done. We're running these because this is very, we're going to talk about, cytosorb, anakinra, cyclosporin, etoposide, JAK inhibitors. I mean, and then it's a minefield. Nobody knows what to do. Shall I just leave this? Or maybe it is, for the wider audience, it is possibly not of much use either. Shall we?
Yes, Ognita, please
Or
go
shall
ahead. Yes, skip it because we want to keep a separate session for that, but the time is less. So that's why I've not kept it here.
Yeah, I think we should just leave that. So basically, the message that should go is, some kids will actually, the majority of HLH kids will respond to this steroid and IVIG plus minus. There will be a small cohort of patients who will not respond to it. They will do very bad. And what should be the best course of action is just not sure. We just don't know. That is how it stands, unfortunately. Anybody would like to say anything grossly different from what did I say? Briefly. Any of the panelists?
Only just a little thing. If the CRP is significantly high, then I think sepsis is possibly present, because what I have observed dengue HLH patients, it's the most of hyperferritinemia because it's IL-18 mediated, not IL-6 mediated. So if the CRP is significantly high, then it's more of a sepsis. So that is one of the things that I would like to state.
Yeah, okay, point taken. But if you know that it is HLH and it is not responding to those two first layers, then what to do is a minefield, really. Okay, so as I've said again, sort of timing is crucial, absolutely. So take home message: HLH secondary to dengue is quite common. I think almost most of the dengue deaths, if not all of the dengue deaths, are actually are related to HLH. It is very important to think about it in the right settings. They do not always need specific therapy. Dexamethasone alone is sufficient, maybe plus minus IVIG. Next options are anakinra, cyclosporin, extracorporeal, JAK inhibitors, anakinra, and all of that. Last two slides. 12-year-old girl presented to A&E with history of high-grade fever for 5 days, vomiting, loose stools for 2 days. Had multiple seizures, was post-ictal. In view of poor sensorium, was ventilated. Neuroimaging performed as well as tests for dengue because it was being the season. Actually, it is one of my real patients. We did the dengue because it was the dengue season, and these are the reports. So white cell bit high, platelets still high, CRP 13, procal high, ferritin 16,000, OTPT both high, dengue positive, and CT brain, bilateral bulky thalamus, hypodensity in the brainstem. And the radiologist gave us a diagnosis of ANIC, acute necrotizing encephalitis of childhood. So what is this? how do you suspect it? When do you suspect it, and how do you treat it? Prabhash. This is our last case.
So acute necrotic encephalitis is a very rare complications of dengue. It's basically part of the expanded dengue syndrome. There are many viruses other than dengue that can cause this ANEC. The ANEC patients usually presenting, though dengue is not traditionally it's a neurotropic virus, but sometimes it can infect the brain. And ANEC is totally different than dengue encephalopathy. ANEC patients present like features of AES. The typical thing is that they usually do not, like classical dengue, they usually do not go into capillary leak and shock. But there are a few indicators that may be susceptible that there may be a dengue, the SGPT usually may be a bit rise, the platelet count may be a low. If you do a dengue serology, it will be positive. And the typical MRI pictures, the bilateral bulky thalamus, like double donut-like signs, these are the with the hemorrhage, the typically of ANEC. These ANEC patients are very bad neurologically. They usually intubated very earlier. Sometimes they develop refractory status epilepticus, some extrapyramidal symptoms as well. The mortality is very high. If they survive usually use lots of morbidity. And treatment-wise, mainly intensive neurological. There is no consensus about the specific therapy. There are only few case reports and series. They are showing that if you start immunotherapy like high-dose pulse methylprednisolone plus minus IVIG, within 48 hours of starting on neurological symptoms, they may be useful. Some of them are using plasmapheresis as well as tocilizumab. But I have encountered 3 or 4 patients like them, only except one, all of them expired.
Right. So, take a message for dengue can cause many neurological symptoms. It can be dengue encephalopathy, it can be dengue encephalitis, it can be ANEC, it can cause even lots of other things, Guillain-Barré. But if your kid is showing a lot of CNS symptoms, it is important to do your neuroimaging first. If your neuroimaging is clear, then it is dengue encephalopathy. Don't worry. And then this ANEC thing is a radio diagnosis. Unless you do your imaging, you will miss the diagnosis. It is a radio diagnosis. The diagnosis will come from your radiology department, right? And prognosis is very bad. About 30 to 40% will die. And then another 40-50% will have significant morbidity. Intact survival is about 10%. They will often not present with leak or hypotension. Their platelet count often will not drop that much. They will be dengue positive. And their treatment is very different. Their treatment is steroid, IVIG, plasma. Some of them, because it is IL-6 mediated, people have used tocilizumab also with some good results. But the point is, the treatment is very different from standard dengue therapy. So it is important, although it is rare, it is important to think about it. And if you are having neurological symptoms, get a get some sort of imaging done fast. Questions? Thank you. I think we have gone over the time, but can't help. Thank you.
Yes. Dr. Mihir.
Stop sharing.
Yes.
Yes, so Dr. Dipankar Majhi has joined. Madam, you can introduce and start.
Yes. Thank you, Dr. Agnishekar, for a nice panel, this moderation, and all the panelists. They have done their wonderful job. Now I will welcome Dr. Dipankar Majhi. He is a Joint Director of Health Service, and he's also the nodal officer and looking after the IDSP and all the communicable diseases of our state. And he is very known to us for all the programs. Whenever we have a program on communicable disease, even vector-borne disease or anything, we found him, and is very cooperative. Always he's helping us for the running the program and all. Welcome, sir. Now we'll hear from you the government program, what we say we're running for this dengue and this dengue season. And please highlight the program and say the government message to all the pediatricians of this platform. So I welcome you, sir.
Please unmute. Dr. Majhi, please unmute.
Yes, thank you very much, madam, and thank you, Dr. Sarkar. Actually, would you please bring my slides to the fore, Dr. Sarkar?
Slides with whom? You have your own slides?
Yes.
Okay. Slide
Yes,
show.
thank you. So my sincere thanks to you, ma'am, for giving me this opportunity to speak before this learned audience. Actually, out of my experience for long years handling this dengue situation in the state, so I would like to share of my experiences, some points about the dengue epidemiology and some point of the larger picture of the clinical features and management, the larger picture. So, Dr. Shaka, please, next slide, please. So, West Bengal, like some other states of the country, is really vulnerable, as you know, to the transmission of dengue due to climate change, rapid urbanization, and huge population movement between dengue endemic and non-endemic areas. And interestingly, what we have seen since last year, particularly, that dengue is now occurring at higher altitudes also. In 2022, we have got lots of cases from Kalimpong town itself, and also from virgin areas like, say, tea garden villages of Jalpaiguri. We got a lot of cases from there last year. So dengue is spreading to newer areas. And this year, the high humidity, as we feel, high humidity and this recurrent light or medium shower continuing, this is creating a huge convenient ground for vector breeding. And we should expect a lot more cases in the coming months. And interestingly, what we see is peri-urban areas, which are under Panchayat administration. Peri-urban areas are seeing a lot more cases than actual cities. So for the peripheral audience of this session, I think who are practicing in the rural and peri-urban areas, they would expect, they should really expect a lot of cases in the coming months. Presently, we are seeing most of the cases from Kolkata and the adjoining districts, but what we also see that it's spreading to the pockets of further districts like Murshidabad, Malda, Birbhum, Jhargram. So it's spreading. Next slide, please. Now, a brief account of the serotype profile that we see in our state. We know in India, 4 serotypes are in circulation, and the same is true for West Bengal also. But the thing is, this predominance of a particular serotype, it varies over the years. From this graph, you will see here we have shown the picture from 2015 to 2022, and these different lines are for the different serotypes. You can see there is lots of ups and downs. One particular serotype went up some year, and the next year it fell down like that. And recently, in 2021, there was a huge hike of the green one is Den. That's Den 3. Yes, Den 3. The green one, Den 3, and it went up very high in 2021. Then came down to some extent in 2022. And the red one is Den 3, it went up. So go to the next slide, please. Yes, in 2022, that means in last year, Den 2 and 3 were the major serotypes. And the difference between Den 2 and 3 that was seen in 2021, that difference has become narrow in 2022, last year. And actually, this is the overall picture, but the picture varies from region to region. If you go to the northern districts, Den 2 was much more than Den 3. Overall, Den 3 was more, but in North Bengal, Den 2 was much more than Den 3 last year. But in southern districts, Den 3 was more than Den 2. So there was region-wise differences also. And what we see this year is just like the end part of last year, Den 3 is taking over Den 2 still now. And also there is a little bit of Den 1 and Den 4. But interestingly, the trend is changing in some places. If you talk about North Bengal, there DEN 3 is first picking up. And in among the southern districts in Nadia, again, DEN 2 is going down and DEN 3 is coming up. So what is interesting is co-circulation of different serotypes is happening, and the predominance, it moves like a seesaw game. So there is this complicated picture makes the situation much more vulnerable for secondary dengue, and obviously for much more number of complications. Next slide, please. The practitioners who commonly deal with dengue cases definitely have seen that the dengue shock, it starts with compensated shock. And the typical picture of dengue is the compensated shock. It comes in a very subtle way. The patient is alert. The hemodynamics are only little deranged. So the signs, the features of the shock are very subtle. And if we fail to identify the shock at this compensated stage, it very fast, it passes on to the hypotensive shock and in a very silent manner. So the clinicians who treat the initial part of the disease, initial phase of the disease, must be very aware of this characteristic of dengue. Otherwise, if we fail to institute adequate fluid therapy at this compensated stage, this will be a very costly miss, because it will lead to further complications in a very short time. So at the initial stage itself, asking about the golden questions to the patient, this history taking part, and also careful monitoring of the hemodynamics, very close monitoring of the hemodynamics must be emphasized. And this message, this being careful about this compensated shock stage, should go to the peripheral practitioners who usually treat the initial phase of the disease. What we have done in our system is we have introduced a top sheet, that is just a monitoring format for every admitted dengue case. In this top sheet, the monitoring parameters are recorded day-wise. So just by a glance, by a quick glance over this sheet, you can understand which parameter has gone worse and which parameter has improved. This will give a cue to you among all the patients, which particular patient is deteriorating. So in our case, we are doing PCV and platelet at least twice a day for every admitted case. And this urine output, you had a long time of discussion on urine output measurement, in particular some case studies. So this urine output being a very objective parameter has got a very important place in this top sheet. So here is just a quick look over the sheet. It's a hard copy format where day-wise boxes are there. The parameters are recorded in a uniform manner day-wise, and this hard copy is attached to the bedded ticket of the patient. So the person, the doctor giving the round, can have a quick look over it. Okay, so next please. Now, what we are seeing in last few years is the complications of dengue are changing. Since say last 2019, particularly from 2019 and very conspicuously in 2022, multi-organ dysfunction has become much more common that we usually used to think of. And in a number of cases, we have seen in a number of cases, irrespective of dengue shock or hemorrhage, vital organ involvement has occurred. So these cases had direct vital organ involvement, irrespective of dengue shock and hemorrhage. So this usually when we treat a case of dengue, we manage a case of a dengue patient, our main focus goes on to identification of shock and hemorrhage and managing those situations. But this changing clinical picture points out that we must be careful about these vital organs. And in addition to taking enough care for shock and hemorrhage, we must also separately give attention to the vital organ functions. Dr. Shokar, please. Next. Another problem in dengue management is the delay in seeking care. Particularly fever cases, attending late to you, to the doctor or to a hospital, fever cases attending late is a real problem in clinical practice. In dengue, it frequently happens so that the patient or patient party fails to appreciate a danger sign. As for example, it's very common. A dengue patient vomiting repeatedly, the patient party gives some antiemetic or does this or that, and they just keep waiting to see what happens. And in this way, a very valuable period of time is lost. Some dengue patients, they complain of dizziness and severe prostration. Often the patient party thinks, oh, it's just due to weakness. Let's wait for some days. With the remission of fever, everything will be normal. So in this way, a golden period of time is lost. And when they actually start appreciating that the sign is something ominous, and they go to a doctor or attend the hospital, by that time it is late. And already the vital organs function has become compromised. This is a very common thing. So appreciating the warning sign is very important from the patient and patient party side, let alone the clinician. So our emphasis is on creating awareness about this warning signs. What we do is we spread health education messages through our machinery of health workers. We have started TV and radio campaign. You will see in major TV channels also this message on dengue home management and warning signs. We are displaying publicity materials in hospitals, making advocacy for medical professionals. And in addition, this year what we are doing is, we know in rural areas, there is a real presence of informal healthcare providers. We want or not, they are there. So we are creating awareness among them also, the rural unqualified practitioners. Yes, next please. In last few years, the extension of dengue testing facility has increased in a large way. We depend actually on ELISA method of diagnosis, and these ELISA facilities are available not only at medical college, but also in district, subdivision, and up to state general hospitals also. Even a few of the high endemic blocks, they also have this ELISA facility. And the large number of blocks, they don't have the facility. They are tagged with some or other testing lab, so that these blocks send samples to the particular tie-up facility and get their results through email. So that sample referral system is very vital one. And apart from these state government facilities, we have 60 and odd municipalities who have also started dengue ELISA testing very recently. And wherever there is a fever upsurge or dengue upsurge, we do fever camps. From these camps also samples are collected. Next, please. So in the last slide, my appeal to the listeners of this presentation is, please preach for early seeking of care for fever. Please do advocacy on warning signs of dengue. And side by side, you may suggest your client to avail of the government testing facility if they require so. And kindly spread the treatment protocols, treatment guidelines, and your practical tips among your peers and juniors. And if the mention of the catch points that I mentioned in this small presentation, if these come to be of any help for you, myself, the speaker, will be more than happy. Thank you.
Thank you, Dr. Maji, because very nice overview, because we are seeing the patient in piecemeal. As a state administrator, you are seeing the overview and the eagle's eye view of what is happening in the dengue all over the state, what is the changing disease, clinical manifestation, epidemiology, starting from the virus to lab facilities, everything. So very nice overview, and we are enriched with your information that you have given. Over to you, Madam and Shakunda. There are a lot of flooded up questions in the chat box.
Yes. I'm requesting all the panelists and the moderators and the experts who are there in the faculty, please answer the post, because there are lots of queries and we are here only to have clear our doubts and all. So please answer. And thank you, Dr. Maji, as if your presentation is so attractive, as if I'm peeping through a window of my state. So it is the view of a state about the dengue and the prevalence, the burden, and the changing scenario of the dengue strains. It is a very nice presentation, very good learning for us also, because dengue strains you have highlighted how it is changed from place to place and different corners of a state. So very nice presentation. And I think if there's any queries about the government program, sir is there. You can ask any government, any queries about the facilities and all. He will highlight us about the, and will show the path. So anyone can ask any question to sir. Any questions from the panelists or any attendees? Of course, from West Bengal, because we have seen lots of doctors join from outside the state also. Thank you for joining in our webinar. So if there's no more questions, we can end here, Dr. Mihir. I can request then Dr. Shapun to say if
Maya Madam has joined. The Maya Madam and Atunuda.
So we are here. We really honored to have you all in the as a faculty, Dr. I think
Atunu can conclude.
Yes. Okay, first I'll request Maya ma'am, because she is very senior and very respectful to us. Ma'am, if you want to say some words about our webinar, আমাদের এই প্রচেষ্টার উদ্দেশ্যে আপনি যদি কিছু বলতে চান।
It's a very nice presentation and very wonderful listening. I am here to learn from you, to recapitulate and learn modern things actually. It's a very nice presentation. Discussion was very nice. All the presentations are very, very, very nice. It is what.
Thank you, ma'am. Thank you, ma'am. Your word is very useful. Now I request Dr. Atunu or Dr. Shapun. Dr. Atunu is here.
Atunu has left.
No, he's here. He's still there. I don't know whether physically he's there or not, but he's logged in. Still logged in.
I could see him. Anyway, thank you, everyone. It was a nice symposium of dengue. And I am thankful to the DHE and the DHS and Dr.
DME, not DHE.
And
DME, sir.
I'm not in government hospital, and that's why.
No issue.
And obviously, Dr. Deepankar Maji, for your lucid presentation. I'm thankful to all the speakers, like Dr. Professor Bhashwati Bandyopadhyay and Dr. Professor Ritobroto Kundu, Dr. Ognishekar Saha and team, Dr. Professor Sumita Basu and the team. I am skipping all the names because Ogni has already introduced them. And obviously, Champakda was sitting throughout the day. So
from the very beginning, ask him to say few words.
Learning a lot. I'm going to face a tough time up to October.
and there was a participation of 195 today.
Yes,
so
that
people
is
very
near
much
about 200.
interested in listening to all the stalwarts of this dengue management, and particularly our intensivist of Kolkata. So Mihir, please try some other session which will be helpful for all the PGTs and even the practicing pediatricians all over the country. And thank you, Professor Kalpana Datta ma'am, because it was your benchine and it was the total trouble taken by Dr. Nidhi Sharma. And thank you.
Yeah, it's totally prepared by and communicated, and all those things are done by Dr. Mihir. So it's a great effort, Dr. Mihir. I must thank you, and I'm really happy to have you all the the executive board members and the OB-EB members of West Bengal Academy of Pediatrics 2023. I'm really lucky to have you. I'm really blessed and having you with us for this mission. Thank you all. And
so
good night.
YouTube link is given in the chat box, so it is available in the YouTube, the recording.
In our website.
Yeah.
And Dr. Mir Sarkar has also posted in the group. They can keep it, or it is very easy to log in just wap.org, and in the website you can find all the YouTubes. So good night.
Good night. Very useful discussion today.